I welcome Dr. Venkatagiri. I welcome today's webinar coordinators, Dr. Rajesh MC, who is the Scientific Committee Chairman of ISA Kerala State Chapter, and Dr. Vijish Muganavabal, who is the Governing Council member of ISA Kerala State Chapter, and the Honorable Secretary of ISA Kerala State Chapter, Dr. Binil Isaac Matthew. I know that there are many teachers who are with us all the meetings, and they were contributing in all discussions. I welcome all of them, all senior teachers and officials of ISA National and other state branches. And welcome all the delegates once again to this meeting. And I hope that this will be a very important meeting, very useful for all of us. And request Dr. Giri for a few opening remarks. Dr. Giri, please.
President Dr. Nazar, Secretary Binil, today's faculties, Academic Chairman Dr. Balabhaskar, and friend Dr. Rakesh, Academic Coordinators Vijish and Rajesh, Past President Dr. Agnihotri sir, delegates, friends, continuing with our regular PG update on every Saturday, we are having it today. Another two conferences are going on right now, Optical Conference online and Maharashtra Council may be having little less attendance. Many may be participating in that, PGs and others. But still, a good number of participants are. We hope get more as the time goes on. And we have good topics, clinical and theoretical, both by Dr. Balabhaskar and Dr. Rakesh Gar. So PGs will make use of these two topics, and it will help them to clear their exams easily. And thank you, and over to you, President sir.
Thank you, Dr. Venkatagiri. I think it's time to go straight to the academics. Over to the webinar coordinators.
Thank you, Dr. Nazar. This is an important session, and we are very fortunate to have Professor Balabhaskar sir with us, who is the past president of the Indian Society of Anesthesiologists and was the past editor-in-chief of the IJA, and as the chairman of the scientific chairperson of the ISA National, he has helped us a lot, given us important tips and suggestions. Thank you, sir, for this, for your help and guidance. And we are this is an important session because it's very difficult to get good teachers who are genuinely interested in basics. And when even for a good student, when the basics are asked during their Viva examination, they fumble. So it's an important topic for the postgraduates as a theory as well as for their practical sessions. And over to you, Balabhaskar sir. I hope PGs will be attending this session, and important sessions are coming in the coming weeks, October also. Over to you, sir.
So, thanks a lot to Team Kerala once again, Dr. Nazar sir, President, and the Secretary, Dr. Binil. And there is an overall guidance from the President-elect of ISA National, my friend, Dr. Venkatagiri. And we have got a pair of, I told you, academicians who are the backbone of this program, Dr. Rajesh and Dr. Vijesh. And I can also see my co-speaker, Dr. Rakesh Gar, an excellent academician himself. And I can see seniors also in the group. I can see Dr. Dash, Dr. Agnihotri sir, and Dr. Anil Malde also. And many of the speakers are also generally have been senior faculty. And I think the benefit has been passed on to the PGs, and the DNB results would also reflect the fruitful effect of the PG update from ISA Kerala. So thank you very much. And when a topic was being discussed with Dr. Rajesh, I said I would want to speak about local anesthesia. And he also discussed that what I am going to speak. And he also said one more speaker had already presented a topic about local anesthetics. I said I want to cover some basics of local anesthesia, which I found I'm definitely finding that the PGs are not knowing, or they are probably looking at more superficial points with respect to local anesthetic agents and concentrating on clinical management. So I thought I will pick up some points which are very relevant to understand, not just for the PGs to pick up for the examinations, but also to carry forward their career in anesthesia. Because day in and day out, okay, we are going to use the local anesthetics. So to begin, in general, when we talk about anesthesia, broadly we say something about general anesthesia and local anesthesia. So when we say general anesthesia, we push a drug, intravenous or inhalation, and we expect the drug mainly to go to the CNS, which is supposed to be the site of action. But even at the level of the brain, they have got multiple theories of action of the anesthetic agents, and we are not sure. And with respect to local anesthesia, we are going to deposit the drug in the vicinity of a nerve or a nerve complex or a plexus or whatever. And we know that these drugs are expected to act directly over the nerves. And they could have some pharmacodynamic effects in other parts of the body. And the mechanism of action of local anesthetics, we have got more clarity as compared to the mechanism of action of general anesthetic agents. So what I am going to speak about is some basics about the anatomy of the nerves and the physiology of nerve conduction, and how the local anesthetics would block the nerves, and some of the important properties which are related to the block. For example, the potency, the duration, and the onset of the local anesthetic effect. Some structure-activity relationships, and definitely I'm not going to talk about the routine things which many of the PGs would be readily knowing, and they would have read already, like the drug absorption, metabolism, the route, dose, toxicity, the different types of blocks available, and the non-block pharmacodynamics and other things. So first of all, this would be the basic diagram or illustration we should be remembering. This is a nerve. Okay, this is a nerve which is covered by a covering. So this covering is called an epineurium. It is mainly a combination of fibrous tissue or a sort of connective tissue, and there could be some blood vessels, lymphatics, and other tissues outside of this fiber, because majority of the nerves are embedded in other body tissues. And if you peel off this epineurium, inside we have got fascicles. So various fascicles are available. These fascicles are bundle of nerve fibers. We can see the multiple fascicles here, and each of these fascicles are covered by what is known as perineurium. So they are present around the fascicle, and within the fascicles are the various nerve fibers. And in between the fascicles, you can see again some blood vessels, including the arteries and the veins, and some connective tissue and the fat also. And going beyond, so if you strip the perineurium around the fascicle, you are going to get the nerve fiber with its coverings. So the nerve fiber is covered by endoneurium. So we have got from within outside endoneurium, we have got perineurium, and we have got an epineurium. So these are the three layers. And once you strip the endoneurium, there will be Schwann cells, and there will be myelin sheath and what is known as myelination. This I will expand here. So if you can see here, you have got beyond the endoneurium, you have got Schwann cells. These Schwann cells are the cells which have got some lamellar arrangement, and they cover the nerves, nerve fibers basically. And this is, for example, the nucleus of the particular Schwann cell. These lamellations would cover the nerve fibers, and each Schwann cell can cover more than one nerve fiber also. It is like a sheath which is covering the nerve fiber. And these Schwann cells, by nature, are basically a set of cells which perform very important functions, in the sense they provide some sort of maintenance, they repair some damage which can happen there to the nerve fibers. They also provide some energy to the nutrients to the nerve fiber. So these are the various works the Schwann cells perform, and Schwann cells themselves would provide a sheath called myelination to the axon or the nerve fiber. So this is the innermost part, the myelinated axon, and if you remove the myelination, there will be a nerve fiber itself. Okay, this is the way the fibers are arranged, and the various structures which we can see when you see a nerve overall. So when I said about myelinated and unmyelinated fibers, so all the nerve fibers may not have myelination. Some are not myelinated. In the sense, there could be Schwann cells, but the Schwann cells will not provide myelination. So myelinated fibers are one set of fibers and non-myelinated fibers are the second set of fibers. So this is the way again the nerve has been dissected here and the nerve fiber has been dissected, and you've got the myelin sheath which is present beyond the Schwann cells. One thing you have to see here is there are what are known as nodes of Ranvier. So these nodes of Ranvier are present at frequent intervals of about 1 to 2 microns along the length of the axon. Okay, these are mainly present in the myelinated nerve fibers. What is the purpose? The purpose of nodes of Ranvier is to receive the impulses and conduct them to the next node and hastening the action potential. So this is the basic work or basic responsibility of the nodes of Ranvier. So in general, based upon the diameter and myelination also, there could be a change in the speed of induction. Larger nerves have got better intrinsic electric contention, and myelination will provide better electrical insulation of the nerve fibers. It's just like the electricity cables which you have got at home and you see. So there are copper wires inside and they are covered with insulation. One of the reasons of insulation is not just protecting us, secondly also because they should not be disturbed by extraneous currents. So here myelination provides that sort of protection and it allows for faster impulse conduction via what is known as saltatory conduction. This we would have heard in physiology and you would have read in our nerve conduction part of anatomy. So this is how it happens. So the first diagram is a bare nerve which doesn't have a myelin sheath. Look at the speed of conduct. And the second one is the one which has got myelination and the nodes of Ranvier. And there is a very fast conduction in the second one as compared to the first one. And one more thing we have to remember is these nerves, the peripheral nerves, are generally a mixture of afferents and efferents, which are subserving various sensory and motor activities, or they could also carry some sympathetic fibers. They could have contain myelinated and non-myelinated fibers, and they could have different diameters. So that's how it is. For example, this nerve bundle or a nerve or a peripheral nerve has got A alpha, A beta, A delta fibers. There are afferents, there are efferents, okay? There are C fibers also. This is how it is distributed. So what we have to understand is there are different types of nerve fibers which are explained anatomically based upon the diameter in nanometer and the conduction velocity in meters per second. So if you see there is ABC from above downwards, there is a reduction in the size of the diameter. Simultaneously, there is an increase in the decrease in the conduction velocity. Okay. So this is one thing. And secondly, also what you have to remember is the A and B fibers are largely myelinated fibers. Okay. Some B fibers are said to be not myelinated, but overall A and B fibers are myelinated and C fibers are not myelinated. And as I told, the speed of conduction varies directly with the size of the nerve or the diameter of the nerve. So thicker the nerve, greater the speed of conduction. So what we have to understand as PGs generally is very simple. The motor fibers, it should come just like that without reading also once you get familiarized with the subject. A alpha fibers are the ones which subserve the motor function. A delta fibers are the ones which subserve the fast pain or the short pain associated with surgeries. And the group B fibers are the preganglionic sympathetic fibers. When I talk about preganglionic sympathetic fibers, these are the fibers which are involved in the sympathetic blockade by central neuraxial block, spinal and epidural, and the patient will have vasodilatation and hypotension. So these are subserved by the preganglionic sympathetic fibers. And they have got C fibers. Basically, they give the postganglionic sympathetic outflow, and they cover the slow pain or dull pain, not the sharp pain. Okay. So in general, as I said, large diameter fibers are very important. Depending upon the criticality of a function, it has been found that large diameter myelinated fibers have been involved in sensory and motor functions, which are very important for day-to-day activity. And the non-myelinated fibers, especially the C fibers, may not be involved in such critical functions. So it may be associated with dull pain, it may be associated with some temperature control and autonomic functions. Now you go to the basic unit of the nerve cell. We have got on the left side the dendrites, which bring the electrical signals from the surrounding nerves or from the source or from the brain or the spinal cord. And it goes to the cell body. The cell body contains the nucleus and the organelles. And there is an axon, so which is a long length, which is present, which conducts the action potential, which is obtained from the axon, from the cell body. And these electrical signals are passed on to further areas in the body, including the effector site, or they may synapse with surrounding nerves. So what will happen? What is the status in a resting neuron? So all of you know, if you can look at the first diagram, generally at rest, the plasma membrane or the nerve cell membrane primarily allows for the potassium to move. Okay. There are very few chloride channels and sodium channels which are open at rest. So whatever happens is mainly the potassium being taken out of the cell, taken out of the nerve cell. So you can see a lot of potassium being taken out of the cell here. And only one channel here of sodium, one channel here of chloride, which is being active and they are being taken inside. So this is a status in a resting cell. What it represents is generally there are 10 times more open potassium channels as compared to sodium and chloride channels at rest. So the net result is there are more positively charged potassium ions which exit from within the nerve cell to the outside or to the extracellular compartment. Outside of the membrane, therefore, has got a net positive charge related to the inside. So on the reverse side, therefore, there is net negative positive charges inside. And if we talk about the electricity inside the nerve, by keeping microelectrode, there is a negative voltage inside. Okay. This negative voltage is the resting membrane potential, is normally about minus 70 millivolts. So all of us know this illustration is very good, obtained from genome physiology. So this is an action potential tracing, and the various activities of the channels are given here on the upper part. Then whether they're excitable or not is given in the second part or in the middle. The lowermost part is action potential tracing. So the resting membrane potential of minus 70 would become changed and keeps on increasing on the basis of a action potential which is received as part of a electric current being passed, or because a tissue is autonomous. So what will happen is there is sudden opening of the sodium channels, and there is a rushing of the sodium inside. And this minus 70 millivolts would result in a plus 30 millivolts inside the cell. Okay, so this is mainly because of the sodium channels being initially be dominantly open, and then the pace of the entry of sodium channels will come down, and the number of sodium channels that are open will come down, and they also start closing, and then the potassium channels open. So there is continued positivity, doesn't come down very fast till about it reaches around again minus 60 millivolts. So this area is called absolute refractory period, where a new stimulus or an action potential will not be able to be created. Okay, the cell will not respond because it is already totally depolarized. Okay, then beyond this, what will happen is the sodium channels are reset and potassium channels will continue to be open as they have been before. Okay, so this period would last for again another 2 seconds, and this is called a relative refractory period, where an electrical impulse can work, but the strength of the impulse has to be bigger than the previous normal impulse. Okay, so this is the only way we can probably get an action potential as a response. Okay, so towards the end, so it has come to a what is known as an inactive phase. So from minus 70 it went to plus 30, then it has come back to around minus 70, and it has reached an inactive phase. So in this inactive phase, both the channels are closed. Okay, and it is time for the next action potential to be created. So I hope it is understood by all the postgraduate trainees. to make it easier to understand again, so if you read this illustration from the right to left in this direction, you can see in a resting state, as I told you, the potassium would be the only channel in terms of the numbers open in greater numbers. For example, here it is shown as only 2 potassium channels being open, going out, and only 1 sodium channel being open and going inside. So there are more negative organic ions inside. So it is negative inside, for example, minus 70. And then if an electric signal comes, is passed on, so what would happen? The membrane would undergo depolarization. So inside becomes positive because more and more sodium will go inside as compared to the potassium. So this is an action effect of the action potential, right? So this action potential becomes propagated. If you see the third diagram, these changes will continue further along the length of the axon, but the previous part will become repolarized. So what was depolarized before will become again repolarized, and the subsequent part will become depolarized. So this is the way the action potential is transmitted along the nerve fiber or the axon. So where do these ions enter? So basically, we are talking about the sodium ion, the sodium which has to enter. It acts through various channels and pumps on the cell membrane. We have got a family of channel proteins. They are called as voltage-gated sodium channels, voltage-gated potassium channels, and voltage-gated calcium channels, along with some other channels and some receptors, which we did not discuss too much. The most important is the voltage-gated sodium channel, which is shown here. Okay, this is the most important one for us. There will be one principal alpha subunit for each sodium channel, and there are 1 or 2 beta subunits, which are auxiliary subunits for alpha unit. So this is the one important anatomic consideration which you must remember. And each of this alpha subunit, again, if you can see here, it has got 4 hydrophobic regions. 1, 2, 3, 4. They are hydrophobic regions. They actually cross the membrane, the whole length of the membrane, if you can see, from inside to the outside, and they surround the pore. This is the sodium pore of the alpha subunit, and they surround it totally. So this is the important consideration. This hydrophobic region would indirectly also represent the lipophilic region, okay, allowing for sodium to come inside in an alpha subunit. So based upon the previous diagrams where I showed the way the electric current passes and the way the sodium channels exist, we can have 3 different states. For example, if it is at rest, the sodium channel, for example, the alpha subunit with 2 beta subunit and other things with, again, the surrounding channels for it, it is resting, and the sodium, so this is the sodium in the extracellular compartment, it cannot come inside. So this is a problem when it is resting, and it is non-conducting. And then once the sodium channels are open because of the action potential energy being transmitted, it conducts the sodium inside, okay, and the channel is open. And once the channel is open for a fraction of a second and sodium moves inside, then the channel starts closing. Okay, now the channel is closed. There is change in some size or conformation, but it is inactivated. So it will not allow the sodium to go inside. So we can have the sodium channels which don't conduct at rest and when they are inactivated, but they conduct only when it is open, when there is depolarization. Okay, so these are the 3 states that the sodium channels would exist. Why it is important with respect to the inactivation is, normally we have what is known as fast inactivation, wherein the channels are open for only a millisecond and then they become inactive. So such channels are sensitive to the action of local anesthetics, because we are talking about local anesthesia and the nerve blockade. And there are slow inactivation channels. They open for seconds to minutes and then they become inactive. They are resistant to the action of local anesthetics. So that will not suit our discussion for the day, because it also depends upon the voltage and the frequency of depolarizing stimulus. Now, we just understood about the normal action potential and the role of the sodium channel and how they go inside and how they open and close. Now we'll understand the dynamics of sodium channel block by local anesthetic agents. For that, we should know some molecular mechanisms of local anesthetics. Mainly, local anesthetic, the block transmission by acting upon the voltage-gated sodium channels, which was discussed in the previous slides. They may also bind to the voltage-gated potassium channels, calcium channels, and the nicotinic acetylcholine receptors and others, and may also directly interact with plasma membranes. But overall, they mainly act upon the voltage-gated sodium channels. So we'll come back to the diagram which I showed you already. So along with the sodium being there in the extracellular compartment, we could also be having the local anesthetic, which we have deposited in that area. Okay. So what could happen here is, in a resting state, of course, it is present nearby, and in the open phase, it can come and occupy the sodium channel, and it could stop the sodium ions from going inside. Okay. And it can also go to inactivated stage. So the local anesthetic cannot act in a resting state. Again, it cannot act in an inactivated state. Just like what I discussed about the sodium in a normal cell. So local anesthetics can also only act and prevent the sodium entry when the channel is open. This is an important consideration. So in general, local anesthetics have got greater affinity if the channels are in open state, not with the inactivated state, as compared to resting state. So never useful if it is already resting. Could have some use if it is inactivated. It could act later, but it is most useful when it is open. So this is called as modulated receptor theory. And in general, as we know, depolarizations will lead to opening and of the sodium channels and then inactivation. Therefore, depolarization is a factor which favors local anesthetic binding. So higher the frequency of depolarization, higher is the number of channels blocked by the local anesthetic agent. So this is called as use dependent block. Now, I told you that the local anesthetic would come inside and it will block the alpha subunit from inside. So it is not that local anesthetics will enter from this part. Basically, local anesthetic will cross the phospholipid membrane of the cell, come into the cytoplasm of the cell, and from here the local anesthetic will go towards the sodium channel. Okay. Higher the local anesthetic concentration, higher is the number of channels blocked by the local anesthetics. So, for example, if I say there is about 5 molecules of local anesthetic here. So these are the 5 molecules which would come inside one by one, then they will be deposited into the cytoplasm. And for example, one will block this channel, another will block a neighboring channel, like that. Instead, if I got about 120 local anesthetic molecules here, because there is a concentration gradient, majority of them will move inside, and these local anesthetic molecules are more likely to block more and more sodium channels. So this is the advantage of having higher concentration. So higher the local anesthetic concentration, higher the number of sodium channels blocked with the local anesthetics. Okay, so what they would do, because of their activity, they will reduce the normal sodium influx. Because of this, they will increase the threshold for excitation and impulse conduction. They will also reduce the rate of rise and the magnitude of the action potential, and reduce the impulse conduction velocity. Okay, these are the various actions of local anesthetic agents. So at some point of time, at certain critical level or higher or highest concentration, the action potential is no longer generated. So that is, I'm talking about a particular concentration, and the impulse that is generated will not be propagated at all. It is terminated or abolished. Okay. So for any given drug, therefore, practically speaking, increasing the concentration can hasten the onset of action. Is there an influence of local anesthetic volume? It is said that certain sufficient volume is also needed to suppress the regeneration of nerve impulses over a critical length of nerve fiber. Okay, I will explain here. There is what is known as model of decremental conduction. So if you see this illustration, the lowermost part shows the various nodes of Ranvier. So this is one, this is one, this is one. These are the nodes of Ranvier. Okay, the left extreme one is a node which is free from local anesthetic. So there is no local anesthetic acting here. So it is producing an action potential tracing, and a current is produced, and this is being allowed to propagate. Okay, but propagation doesn't happen because there is a decay of action potential with the distance of the nerve fiber, because the subsequent nodes of Ranvier are exposed to local anesthetics. Because they are exposed to local anesthetic, there is a decay of action potential with the distance of the nerve fibers. And even the next part of the membrane or the nodes of Ranvier, there is no scope for regeneration of the impulse. So it's also affected. And to the extent, at some point of time, the nerve transmission totally stops. Okay, so if you take these are the different impulses, the nerve transmission totally stops, and it will be so slow, so much resistant. Sometimes they can skip the subsequent nodes of Ranvier if there is a dominant action potential. So they may skip some of the nodes of Ranvier and straight away go to a distal Ranvier. So these also can happen. So there are so many complicated things are happening, so that we cannot predict what is going to happen to an action potential proximal to the area where local anesthetic has been administered. Okay. Overall, it is said, therefore, the concentration volume of the local anesthetic both influence the sodium channel blockade in terms of number of channels and the length of the nerve. Okay, so the mass of the drug becomes more important, not just the volume or the concentration of the local anesthetic agent. Now, we'll talk about the myelination and the nerve diameter with respect to the local anesthetic drug which we are using. So this table we have already known. So we have got A, alpha, beta, gamma, and delta fibers, and B and C fibers. And I explained to you, there is A and B are myelinated fibers. C is not myelinated, and the nerve diameter is highest above, and it becomes less as we go down. But the conduction velocity is highest above, and it comes down as we go down the ABC fibers. Right? It is generally said the smaller diameter fibers have got increased sensitivity to local anesthetics. Okay, whether it be myelinated or unmyelinated, smaller the diameter, they have got greater sensitivity for local anesthetic agent. And within A fibers, for example, we have got A alpha, beta, gamma, and delta fibers. The larger, faster conducting A alpha fibers are less sensitive to local anesthetic than smaller, slower conducting A delta fibers based upon this principle. Okay. And based on this also, we can say the onset of block in a peripheral nerve could be mainly autonomic nerves being affected first, because they are the smallest nerves, before the sensory nerves and before the motor nerves also. Okay, so you would have understood about this when you talk about spinal anesthesia with respect to the levels of block. We say that the autonomic level of blockade, the preganglionic sympathetics are affected about 2 segments higher than sensory, and the sensory are blocked for about 2 segments higher than the motor blockade. So in terms of a peripheral nerve, autonomic nerve fibers could be affected first, then the sensory fibers, and they are most sensitive, and least sensitive are motor fibers with respect to the block for local anesthetic agents. Of course, it also depends upon many other factors related to the drug itself. So overall, based on the diameter and thinner to thicker, we can see an ordered blockage. So this is there is a possible overall order, so that the temperature sensation is the first one to be blocked, followed by proprioception, then motor function, then sharp pain, and finally light touch. So this is called the differential blockade. Okay, and this also depends upon the drugs. I will not go into the details, but basically it is found that bupivacaine and ropivacaine are more likely to be involved in differential blockade as compared to other local anesthetic agents. Okay, so you should understand the definition of what is known as differential blockade. There could be some exceptions, and we may not have explanations also here. For example, the A delta fibers. Okay, we know they are myelinated and big fibers, not small fibers, but they are preferentially blocked early as compared to the C fibers, which are non-myelinated or thinner. Okay, so it is probably good also by nature, because the sharp pain which is carried by the A delta fibers are preferentially blocked over the dull pain which is picked up by the C fibers. And even within the C fibers, we have got fast and slow components which will differ in susceptibility to the block. Okay, this is a problem. Next concept, a related concept I want to explain is the principle of core and mantle fibers. So this is a cross section of a nerve, a mixed sensory and motor nerve. So if you look at the cross section, we have got multiple fibers. Okay, different sizes are present, and these are, for example, A alpha fibers and A beta and A delta fibers, which are predominantly present in the center, and the A delta and the C fibers are predominantly present in the periphery. So this is an explanation for what is known as mantle fibers. Those which are present at the periphery are called as mantle fibers, and those which are present at the center are the core fibers. So what are present at the periphery? They are the ones likely to be blocked first by a local anesthetic at higher concentration. Why I am trying to tell you, see if the local anesthetic is placed around the nerve here. So you got local anesthetic here, and all, it is deposited. So the earliest nerves to be reached are the mantle fibers, and higher concentrations of local anesthetics which are placed around the nerve are going to enter into the nerve and they are going to block. So, and this block manifests proximal to distal, easy to understand, because the nerves as they go down and for the distribution, the most extreme peripheral nerves are the ones which go and divide to subserve or go to different nerve receptors. So the block would manifest proximal to the distal, and block resolution will happen in the reverse way, distal to proximal. And usually because they are so near, they are blocked completely. Whereas the core fibers are the last to reach and at lower concentration because they are inside, right? This you understood. So that is one problem, and we may not be able to block the motor fibers as much as we desire, which I told you in the previous slide. And second factor that could happen is the local anesthetics could be preferentially cleared from the core fibers because there is a lot of blood supply in the core. So there are a lot of blood vessels in the core part of the nerve, and the core fibers where the local anesthetic probably would diffuse ultimately, they would also get picked up and get eliminated for metabolism. So this is a problem with core fibers block. So coming to discussing about the deposition of local anesthetic. So generally, if you see here, this is a nerve. So when you try to block a nerve, so whether it is a brachial plexus block or for example, median nerve block or sciatic nerve block, we are going to go through different planes. So you are going from beyond the skin for superficial nerves, or there are limited planes. When you are going inside, there are a lot of planes. So there could be fat, there could be muscles, there could be blood vessels and lymphatics, there could be connective tissue and everything. There you are going to deposit your drug with a needle. Okay. What should happen? What would happen is basically there is movement across a concentration gradient from the cell, from the extracellular compartment where you have placed the drug into the nerve fiber. Okay, and you expect the drug to go into the different nerve fibers also separately. Okay, so normally it is concentration gradient, but despite placing the drug proximal to the most nearest part of the nerve, it is said only 1 to 2% of the local anesthetic ultimately penetrates into the nerve. Very small, 1 to 2% of what we have given only would go inside. So rest of them would be there, gradually exchanging and going inside or getting absorbed and getting metabolized, right? So this is a principle which we should be thinking about. Of course, we have got the nerve locator guided injections which are being done where you can go more nearer the nerve, and we have got more importantly the ultrasound which is available. So what would happen is we are able to identify the structures clearly. We are going to as nearer the nerve or the nerve vesicle as possible, so that we bypass some of these the tissues which are around, including the muscles and nerves, and they are also getting absorbed, and the blood vessels, they are also getting them absorbed. So when we talk about this is a nerve which I had already discussed about. This is a nerve which has got an epineurium, and we may place the drug in the paraneural area. Okay, paraneural is just outside the nerve with the connective tissues, and this could be a good location, but still there are blood vessels here. Or we can go subepineurial extrafascicular. So you can see we can deposit them in between the fascicles. There is one fascicle, there is another fascicle. Okay, this can be done, and intrafascicular injections can also be done based upon the correct location using ultrasound. So we've got different types of nerve blocks. The frequent research is about the extravesicular, intravesicular, and subvesicular injections which have been discussed. So definitely the pharmacokinetics and the amount of local anesthetic enter now will change. So our principle of talking something like this, only 1 to 2% going inside, is refined, and we'll be able to use lesser concentration possibly, and even lesser volumes. All of us know lower volumes of local anesthetics are allowed to be used when you've got nerve locator, and better still with ultrasound directly. For example, for brachial plexus, in a landmark-based approach, somebody would use 30 ml. If you use an ultrasound perfectly, you may be using only about 6 to 8 ml. But it's the way you place the drug. And there is a small difference between peripheral and central nerves. So generally, I talked about the coverings for the peripheral nerves, right? What about the nerves within the spinal canal? We talk about the central neuraxial blockade. So if it is subarachnoid block, generally it is a naked nerve. You know, it is not covered by the meninges, and the nerve is floating in the CSF, and we deposit the into the nerves there, and it acts very fast, that you know. And if it is an epidural one, there is a dural covering. Okay, it covers till its exit, and the drug will take time to enter, and the dose of local anesthetic in general is supposed to be almost 10 times as compared to the intrathecal nerve block. So thus, local anesthetic blockade of nerves is largely local anesthetic concentration dependent. It could be volume dependent, membrane potential difference. I said there must be depolarization for the drug to act. Frequency dependent, more frequent action potential, more number of sodium channels being open. Nerve thickness dependent, thicker the nerves, it is less sensitive. Smaller nerves are more likely to be blocked, but there are exceptions. And site of local anesthetic deposition. These are the various factors. When I said about concentration and volume of local anesthetic agent, okay, and I also informed that the mass of the drug delivered is the one which is important in the success of the block. Okay, we can increase the volume and we can increase the concentration also. It can increase the success of the block. So based on this, can we have a measure of the potency of local anesthetic? Let's take what we talk about MAC for inhalation agents. Okay, or for example, the percentage inhibition of a twitch response for relaxants. So, do we have some measure? One measurement has been proposed called minimum concentration, or CM. Basically, it is the minimum concentration of local anesthetic needed for conduction blockade, right? But it has been described in the sense, in terms of a critical length of the nerve fiber, right? When I say certain length, generally it is said it should be covering about 2 centimeters approximately, or at least 3 nodes of RAN wire, to say that this is the minimum concentration of local anesthetic required to block 2 centimeters segment or 3 nodes of RAN wire. Of course, these are all laboratory discussions. This can be tried, and it has been tried to be explained also. But problems are more with respect to the definition. So generally, on a academic level, we can say motor fibers would require 2 times the minimum concentration as compared to the sensory fibers. A larger nerve fiber requires a higher concentration of local anesthetic agent. I told you, thinner nerves are more likely to be blocked and blocked early. Thicker nerves may not be blocked and blocked late. Supposing we increase the concentration to 2 times, motor fibers are more likely to be blocked. Okay, larger fibers, larger concentration, smaller fibers, smaller concentration. And there could be local factors also. If, for example, if there is a higher tissue pH and increased frequency of nerve stimulation, they would also help in reducing the minimum concentration for blocking the drug. Okay, so there are other factors, however, because potency is another factor. It's not just a concentration that would affect this discussion. There are certain differences in the intrinsic conduction properties of the drug, and even the binding affinity of local anesthetics to the ion channels also varies. Okay, these are the important considerations. So we cannot have a measure like minimum concentration of local anesthetics to describe the effect of local anesthetic agents, because individual nerve fibers differ in their minimal blocking concentration, and in fact, some thicker fibers may be blocked by lower drug concentration than thinner nerves. Then we'll go to the third part of our discussion today, some structure-activity relationships of local anesthetic action. So largely we know there are 2 types of local anesthetic systems, the drugs So there are basically there is an aromatic benzene ring which is lipophilic, and the other side you have got a tertiary amine which is a hydrophilic group, and in between there is an intermediate chain. Okay, if it is an ester, we call it as ester local anesthetic agent. If it is an amide, we call it as an amide local anesthetic agent. So ester would have a COO group and an amide will have NHCO group. Amine, NH basically. So it's the one which differentiates the ester and the amide local anesthetic agents. So in an aqueous solution or in a blood tissue or in a physiological pH. For example, when I say aqueous solution is the drug which is given is in the bloodstream, or drug is deposited nearer the extracellular area of a nerve which is to be blocked. Okay. The drug will exist mainly in an ionic form. Okay, ionic form. So ionic form is it's a cationic form. Otherwise, we call it as protonated form. Protonated form is there is a hydrogen ion. Okay, and there is a lipid soluble form which is neutral, represented by B. Okay, so at physiological pH, there is an equilibrium maintained in terms of the amount of the drug in a cationic form or ionic form or protonated form or one which has got hydrogen ions, and lipid soluble form or neutral form. Okay, there is some amount of equilibration that is maintained. This cationic form is the one which is not lipid soluble, whereas the neutral form is the one which is lipid soluble. Okay, this we have to understand. Again, coming back to the screen for further discussion. So we have in general for example, you pick up lignocaine or a bupivacaine from a vial. So these vials are made water soluble because generally they are not water soluble per se, and these local anesthetics are made water soluble by adding hydrochloride. So they are made acidic. Okay, so this is the B is the base drug, and it is added to the hydrochloride. It is the way it is there in the bloodstream or nearer the extracellular compartment where you are depositing the drug. Okay, so in the extracellular compartment outside of the nerve, this splits and there is formation of an ionized form here. So you can see here the original drug which has been administered breaks down to form an ionized form. Okay, this ionized form will break into an unionized form and hydrogen ions are released. Okay, right? This unionized form is a free base and it is lipid soluble and it is able to cross the phospholipid barrier of the nerve cell membrane. Okay, once it is inside, it again adds up the proton in the form of a hydrogen ion, becomes ionized, and this is the ionized form which goes and binds to the sodium receptor and blocks the channel. Okay, so what you have to understand is it is the ionized form which is going to act inside. Unionized form is the one which is going to bring the drug from outside to inside. So with respect to how much of the drug is in unionized format and how much of that is in ionized state in the extracellular compartment, there is a definition called dissociation constant which you must understand. So dissociation constant or the pKa is a pH of that particular extracellular area or the bloodstream or the environment at which 50% of the drug is unionized or neutral and 50% is in ionized form. Okay, so this is the same discussion here. So this is a ionized component. Okay, it becomes unionized, goes inside because it is lipophilic. Inside it binds to the hydrogen ion. It becomes ionized, and ionized one is the one which is going to block the sodium channel. So we have to understand this dissociation constant, and any drug which has got a pKa which is closer to the physiological pH of blood or the tissue, for example 7.4, it will have greater concentration of the non-ionized base. And if it is so, it will have a more rapid onset of action. Okay. It's also possible that we can have a drug with higher pKa, right? Is it possible to shorten the onset time? It is possible by increasing the concentration. Okay, I'll give an example. Lignocaine has got a pKa of 7.9, whereas chloroprocaine has got a pK of 9. Right. So if you per se think about the pK of 9 for chloroprocaine, very minimal quantity of the drug would be in unionized state, and that minimum quantity of drug will not be able to produce a blockade. Right. So what is done clinically is its concentration is increased to 3%. So more amount of volume of the unionized component is available. That will allow the drug to be acting faster. Okay, more molecules are available and they diffuse into the nerve and produce a blockade. So this is the basis of increase in the concentration in a different context also. So the pKa can be found based upon the Henderson-Ashby equation. So based on this equation, we can have the pKa of different drugs also calculated. So if you look at this table of the various local anesthetic agents, this is a pKa, that is the ionized component, first part, second is the unionized component. So if you can see, the middle part, which are part of this the rectangle, mepivacaine has got the highest amount of 39% of unionized component at a pH of 7.4. Next, you have got etidocaine is 34, and lignocaine is 24, prilocaine is 24. Right? Look at the esters down. So 3 esters, chloroprocaine, procaine, and tetracaine have got very minimal unionized component. Okay, so if it is so much in minimal unionized component, what will happen is the onset will be delayed, and we can improve the onset by probably increasing the concentration. And because we normally use lignocaine and compare it with mepivacaine, you see, lignocaine has got 24% as unionized component, mepivacaine has got 70% unionized component. So if you compare these two, what we can say is lignocaine has got faster onset, mainly because it has got more amount in an unionized state at a physiological pH. Understood? One more question which we normally face in examination is examiner will ask, for example, if there is an abscess in the foot or in the hand. So how do you give local anesthesia? Is it possible to give local anesthesia? One of the problems which can happen when we try to give anesthetized an area which is infected is that area would have become acidic. Okay, presence of pus would make the local area acidic, and this acidic environment has got one problem: it reduces the unionized fraction of the drug available for diffusing in and trying to act. Okay, so when we give a drug like lignocaine, it is a problem, and if you try to give mepivacaine, it is more problematic. Okay, it's not going to act at all because there is an acidic environment. Secondly, an infected area will have probably more, as much as the maximum vasodilatation will be there in that area. And this increased local vascularity can remove the drug from the site of injection. So this is the problem with the area where there is already infection. So we can also calculate the amount of the unionized portion of a drug based upon the pH also. For example, if the pH is 7.4 in that area, normally we told about 24 to 25% of the drug is unionized. For example, for lignocaine. If the pH is 7.1 in that local area, for example, I told about the pus area where you want to do an IND, where the pH is 7.1 and you are trying to deposit the drug. If you do that, apply the Henderson-Ashby equation, the percentage of the drug in unionized state would come down to 14% from 25%. Okay, for lignocaine. So what I'm trying to suggest is you can also mathematically calculate. Of course, you should have the pH. This is mainly an hypothetical one. So the amount of unionized portion would come down from 25 to 14%. So what you have to understand is that pKa would be affected by local pH also, and the amount of unionized form will also come down. So majority of the commercially available local anesthetics, I told you, are water-soluble hydrochloric salts with a pH of around 5.5 to 7. We can try to alkalinize them. Okay, so one of the popular methods is to use sodium bicarbonate, approximately 1 ml of 8.4% solution for each 10 ml of lignocaine, or lesser concentrations 0.1 to 0.05 for each ml of mepivacaine and other things. It is expected to speed the onset and improve the quality of the blockade. Of course, the effect is not much with mepivacaine. With respect to lignocaine, it is possible that there is an increase in the fraction of the free base, the lipid-soluble form or the unionized form, and it will help in using lignocaine to hasten the onset of blockade. Carbonated local anesthetics have also been described in the textbook, but generally it is found that they may not be as useful as they are claimed, because once they cross and go inside the cell, it is said it is a very transient action and they get almost inactivated once they have crossed inside, also affecting the base levels. Okay. This ionized fraction that is seen in the neuroplasm may not be adequate, or it will be distributed in an uneven manner. So practically speaking, carbonation may not be useful. Possibly alkalization using extraneous sodium bicarbonate could be useful. Next, we go to the potency of the local anesthetic agents. So majority of the anesthetic agents per se, we say the potency is determined by its lipid solubility, because all drugs, especially anesthetic agents, have to cross a cell membrane of any type, and including the nerve cell membrane, which is rich in the lipid layer. So there is a phospholipid bilipid layer which is present, and the drugs have to cross. So any drug which has got better lipid solubility, it is supposed to have a better potency. So in general, the lipid potency or lipid solubility for the local anesthetic is provided by the alkyl groups, such as methyl, ethyl, propyl, butyl, and pentyl groups. So these provide the lipid solubility for local anesthetic agents. So more the lipid solubility, greater is the potency, and simultaneously longer duration of action. Okay. This I will explain later. So lipophilic property would allow the drug to cross to the lipid membranes, as I told you already. And even once inside, these lipids, the propensity for lipid affiliation would help in better binding to the sodium channels. Okay, this is the advantage of the drug being more lipid soluble and being more potent. And potency is generally discussed in terms of some partition coefficient with respect to the fat. We have got one term which is called high octanol buffer partition coefficient. So any drug which has got a greater octanol buffer partition coefficient is got more potency. Okay, and any drug with greater lipid solubility, it is said it will have greater affinity and loss for a longer time in terms of its binding to the sodium channels, and can also produce longer duration of action. So based on lipid solubility, we have got the definition of potency of local anesthetic agents, right? We have got low potency drugs, you have got intermediate potency drugs, you have got high potency drugs. They are basically related to the lipid solubility. So there are three groups. If you can see, the low potency group have got low lipid partition coefficient. Intermediate group have got 1 to 3 octanol buffer coefficient, and high lipid solubility coefficient is present for high potency drugs. Understand? So they are more lipid soluble. So if you see in the reverse direction, the concentration of the drug required to produce local anesthesia is less for highly potent drug. It is less than 1%. It's only 1 to 2% for intermediate potency drugs, and it is 2 to 3% for low potency drugs. That's why for procaine, chlorprocaine, generally 2 to 3% is used, and generally 1 to 2% is used for lignocaine, bupivacaine, pilocaine, and other things. And for high potency, we use less than 1%. For example, the bupivacaine and ropivacaine, normally we use very low concentrations. So we can have relative potencies of local anesthetic agents also. For example, we have a drug group here. We have got relative potency of 8, 8, 8 shown for bupivacaine and levobupivacaine. They have got greater lipid solubility of 1000, whereas for tetracaine is only 200. But there are other physical chemical properties which make tetracaine a potent drug. And ropivacaine, you see, even though it has got a similar structure related to bupivacaine, it is one of the isomers, but still its potency is reduced by almost more than half. Okay, this is related to additional properties with respect to the isomerism, which I will discuss later. Then duration of action. So we discussed about the onset of action and the PK and other factors. We discussed about the potency of the drug. Now we discussed about the duration of action of local anesthetics. Generally, local anesthetics, just like many other drugs which are administered extraneously to the body, they are bound to proteins, mainly alpha-1 acid glycoprotein, and to a lesser extent to the albumin. Higher protein binding is a longer duration of action because it holds to the drug and there is distribution throughout the body. And greater protein affinity will also cause longer duration of binding to the nerve membrane, which I mentioned already. Secondly, potency itself can also indirectly provide for prolonged duration of action. highly soluble agents can bind to the receptacles or the various sodium channels, and there will be longer duration of action. And secondly, there will be slower diffusion from the lipid environment to the aqueous bloodstream. Okay, so any drug, it will go into the fat deposit areas and then get released slowly. So this also adds to the prolonged duration of action of highly lipophilic drugs also. So in general, ester local anesthetics are minimally bound. So if you look at the lower part, so the ester local anesthetics are minimally bound, 7%, 6%, except for tetracaine, and amides are more extensively bound, right? So to the extent of 94%, basically for etidocaine and bupivacaine, and tropicane is 94%. Okay, for lignocaine, protein binding is 95%. So when we talk about duration of action, the drugs which around 95% of protein binding and 94%, they are taken as long duration. Drugs of around 65 to 77% and 55% are shown as moderate duration drugs. Short acting are basically the chloroprocaine and procaine, where the protein binding is again 7 and 6%. So this is a broad idea you have to know. But again, there are exceptions because individual drugs vary. Tetracaine of 75% protein binding, it's long acting. Okay. Then we have got etidocaine, which is 94% protein bind, but it is got moderate duration of action. Whereas ropivacaine is 94%, it is explained as drug with longer duration of action. Then there are certain peripheral vascular effects of local anesthetic agents, which we have to understand because they can have a bearing on the potential duration of action. In general, all local anesthetics have got some intrinsic local vasodilator properties, especially when they are used at lower concentrations. For example, prilocaine has got better vasodilator property as compared to lignocaine as compared to bupivacaine and as compared to ropivacaine. So that means lignocaine is a very good vasodilator, which among the drugs we use regularly. When it is used, it is possible that higher amount of the drug locally will get absorbed into systemic circulation and undergo metabolism, and that it will reduce the duration of action. Okay. And all the drugs which use in very high concentration, they can precipitate vasoconstriction. And among all the local anesthetics, basically, cocaine is the only vasoconstrictor. The rest of them are all vasodilators at the routine clinical concentrations that are used. And of course, the duration of action would also be influenced by deliberate administration of vasoconstrictors along with local anesthetic, epinephrine or phenylephrine, and opioids by different mechanisms, alpha-togenes by different mechanisms, dexamethasone by different mechanisms can also prolong the duration of action of local anesthetic agents. I am not going into those details. And you have got even sustained release formulations of liposomes or even microspheres, which have been discussed. They can also prolong the duration of local anesthetic agents. So I have been discussing about the sodium channel blockade and how the concentration happens, how it goes inside and all, and the unionized portion going inside, ionized portion inside, going and blocking the sodium channel and preventing the sodium entry and causing the depolarization to be blocked. But there is an alternate mechanism which may have some role, okay, called membrane expansion theory. The unionized drug, or the one which is lipid soluble or is got high lipophilicity, will dissolve into the phospholipid membrane from the place where it is deposited. Okay, and it can cause a swelling of the sodium channel or the lipoprotein matrix and cause inactivation. Okay, sodium channel is affected in a different way by membrane expansion produced by the high amount of drug within the phospholipid membrane. So this is an alternate theory put forward for mechanism of action of local anesthetic agent. I am coming to the final part, next 3 to 4 slides. You have to understand some technical terms called isomerism and enantiomerism. In general, molecules of same atomic weight or the atomic or the molecular weight or formulae can have some differences. Okay, they could be similar in terms of their atomic weight and formula or the molecular weight. They can have different structural bonding of atoms, right? For example, this OH here is placed here and it is placed at 12 o'clock position and there is some splitting up here. This is called a structural isomerism. Okay, but their molecular formula is similar and the molecular weight is also similar. Or they could have similar bonding but different 3D configuration. It is called a stereoisomerism. If you can see here, this upper part is similar, the lower part is just twisted, that's all. So there is a different 3D configuration. This is called stereoisomerism. And there is one more called optical isomerism, where a monochromatic plane polarized light is allowed to pass through the particular object or the drug, and the plane of the incident light is rotated. Okay, this rotation of the polarized light could be on the right side or the left side, or dextro or levo rotation, D or L, or we call it as plus or minus. This is called optical isomerism. Okay, this principle has been used for many drugs, including local anesthetic. And another one is called enantiomerism. So if you keep your hand in front of the mirror, okay, you'll get a mirror image. But if you show the right hand, okay, the mirror will show your left hand, right? So this is called enantiomerism. Most of the molecules in life are similar. They follow this principle. In Greek, chair means hand. And this chirality, this is a chirality property. And these mirror images cannot be superimposed. Like definitely you cannot superimpose the left hand which is shown in the mirror with the right hand which you are holding in front of the mirror. So there is always some sort of asymmetry in life. Okay, this happens because of the presence of an asymmetric carbon atom. For example, this is supposed to be the asymmetric carbon atom or quaternary nitrogen, and generally it is bound to 4 dissimilar groups. Okay, you can see here, this is taken as the carbon atom, asymmetric carbon atom, and this is a chiral structure, right? So if you look through the carbon atom and look at the nearest low molecular weight component, okay, there are 4 subunits as I told you already. I'm making it simple for you to understand. Okay, there are 4 molecules. You look at the smallest molecule and try to track the molecules in terms of increasing molecular weight. Okay, so if the increase in molecular weight is in a clockwise direction, it is called a racemate form. And if the increase in the molecular weight is in the opposite side, anti-clockwise, okay, it will be a levo form, right? So these are called as enantiomers. R and L are called enantiomers. And the combination is called a racemate or a racemate mixture, where R and L forms are equally present. Okay, I hope you have understood. Generally, the drugs which we use, majority of them are racemate mixtures. They are combinations of both R and L forms, but their effects on the body, okay, could be different. R form could be producing some effect on the body. L could be producing some effect on the body. Some of them could be beneficial, some of them could be not beneficial, and some of them could be harmful also. One example is with respect to the thalidomide in 1950s. You know, thalidomide widespread use in pregnant patients those days resulted in children born with seal limbs. It was a big catastrophe those days. Subsequent investigations showed that the S isomer of thalidomide was responsible for producing the defect here. Okay, the teratogenic effect of thalidomide. So that is so important now. So the same principle would also be applying for local anesthetic agents. So we can have enantiopures, means pure R forms and L forms which can produce. This is called enantiopure mechanism. And we can have a change in conformation of R and L forms, and we can have specific biological effects as desired, right? So for example, we have mepivacaine, bupivacaine, and bupivacaine. So these are 3 drugs. So these drugs have got a specific group which is commonly present called 5-polyl xylidine. Okay, these 5-polyl xylidines have got one chiral center. So this is the chiral center for all the 3, right? And if you have the methyl group, it becomes bupivacaine. If you got a propyl group, it will become propivacaine or bupivacaine. And if you have got a butyl group, it will become bupivacaine. Okay, so this is one example of this enantiomers, right? I hope you understood. This is the carbon chiral center, and there is replacement with methyl group, propyl group, and butyl group. So this will confer different properties on the different drugs. in general, bupivacaine, levobupivacaine, when we talk about levobupivacaine, right? Levobupivacaine is a levo isomer. All the properties are same, but they are optical isomers. We say it is more motor specific, and we also say it has got better cardiac profile. Ropivacaine, okay, it is the optical isomer. It's not an optical, it is an enantiomer or enantiomer. It is much less lipophilic than bupivacaine and levobupivacaine, and it is less potent. Okay, less potency. Practically, it is said it will produce more vasoconstriction. It will not produce vasodilatation, and this potency is improved because of the vasoconstriction it produces. And it also has got motor sparing effect, has also got cardiac safety as compared to bupivacaine. Okay. So if you look at this table, bupivacaine and levobupivacaine, I told you, are just the optical isomers. All the physical properties are similar here. And whereas with ropivacaine, it is an enantiomer, the potency has come down and the partition coefficient also has come down. So this would result in a weaker drug, but a safer drug. Final slide is about the local anesthetic preparation. Just for you to understand, all the local anesthetics are weak bases when we discuss theoretically, but they are not soluble in water. So the viols and the ampules which you get are made water soluble by adding hydrochloride and then dissolved in saline. So though they become acidic solutions with pH of 4 to 6.5. And this acidity will cause a maximum stability in the solution, and the shelf life will reach almost 3 years. So these are the advantages of adding hydrogen chloride or hydrochloric acid to the local anesthetic agent as a base. And in adrenaline containing solutions, if you go back and check, there will be sodium metabisulfate which would be added as a reducing agent. This is expected to reduce oxidation and prevent oxidation and enhance stability of adrenaline. Okay, otherwise adrenaline will become unstable and it will not be able to produce the desired effect. Okay, and in general, non-adrenaline solutions have got a higher pH. Right. So if it is a higher pH, basically the potency is expected to come down. And in general, the multi-dose vials of 30 ml for lignocaine or 20 ml for bupivacaine, they also have got some preservatives or fungicides which are added. It could be methyl p-hydroxybenzoate, the methyl paraben, propyl paraben, and others. They are the ones which are responsible for the adverse effects such as allergic events attributed to the amide local anesthetic agents. They are not related to the actual drug adverse effects. So these are the important things which you have to understand with respect to the preparation of local anesthetics in general. So now I have come to the end of the presentation. What I have highlighted basically is the normal anatomy of the nerve fiber, normal physiology of the nerve fibers, what is the role of the myelin sheath and the Schwann cells, and the role of the sodium channels around the nerves. Then I spoke about the local anesthetics ability to cross the phospholipid barrier of the nerve cell membrane. Then what are the factors which would affect the onset of action? What are the factors which would affect the duration of action? What are the factors which would affect the potency of the drug? Which are the most important components? And then I spoke about some alterations in terms of the concentration, in terms of the dilution, in terms of the volumes and their effects upon the blockade. And finally, something about the preparations and some modifications of the structure, including isomerism and enantiomers. So thank you very much. And it was a basic topic. I hope you have taken home some important message. All the best. Thank you very much. Thanks to the organizing committee. Thank you.
Thank you, sir, for the excellent lecture. It's open for discussion. It's understanding the basics is very important. Only then you can probe around the subject. I don't think there is no questions as such. We'll wait for the comments from the senior faculties. So there is one in Indian local anesthetic, that's Sendukridine. So it was a quinoline, it was a quinoline derivative produced by the Central Drug Research Institute, Lucknow. But unfortunately, I don't know what the reason it hasn't taken off. It was supposed to be less toxic than the presently available local anesthetics, but it was once a popular agent among ophthalmic surgeons. 0.5% Sendukridine.
Yeah, this is one of the questions I would generally would be put to the postgraduate examination. Okay. What is an Indian local anesthetic? Basically, yeah. So one of the apparent reasons was it did not give any extraordinary advantage over those contemporary local anesthetics it gives. Basically, its action as 1% solution was said to be equivalent to the action of the spinal lignocaine at 5% in terms of the block characteristics. Okay, the 1% drug was supposed to be used, and there are some publications of Indian Journal of Anesthesia those times. Even now I have about 2 to 3 articles which are coming in the IJA, and the block characteristics were similar to the 5% heavy lignocaine used for spinal anesthesia. The apparent discontinuation from practice and stoppage of manufacturing was it didn't offer any greater advantages. And of course, I think no pharmacy company took it up, and as usual, marketing would have been insufficient.
And sometimes when applied ophthalmically, it can produce long-lasting irritation. It's long-lasting than Silocaine, no?
Okay. The ophthalmic application. So I was specifically talking about the spinal anesthesia. So it's quite a basic topic. I think the boys have no questions to ask. Basically.
Sir, I am Dr. S.G.K. Murthy. I wish to ask one question.
Yes, sir. Yes, sir.
Oh.
Brilliant.
Actually, this xylocord is given intracardiac. So, if the dose of the xylocord is more, will it impede with the normal conduction also? As you told that it will block all the sodium channels, and if we give xylocord, is there a possibility of blocking the normal conduction of the heart also?
So one difference which we can talk about here is much of the discussion today focused upon the administration of local anesthetics being deposited in close proximity to the nerves or the plexuses in different parts of the body. That's the first factor, sir. And second factor is when it's administered IV, as you are suggesting, the xylocord, it is a preservative-free local anesthetic agent, lignocaine. So there are specific indications for which we are used to as anesthesiologists. So we administer it to attenuate the intubation responses normally. We try to use it to break up the laryngospasm. Okay, and we, for example, try to pre-administer or mix with propofol to reduce the pain on injection, or we may use it for, of course, IVRA. So these are some of the applications purely for anesthesia indications. So when we talk about the cardiac indications, so we have got the dose requirements, which is mentioned as about 1.5 to 2 milligram bolus, followed by a continuous infusion with an aim to maintain a constant therapeutic concentration addressed towards basically treating the ventricular dysrhythmias. Okay, so normally we talk about usage for reducing the ventricular ectopics and preventing the ventricular ectopics from degenerating into ventricular tachycardia and ventricular fibrillation and death. This is the reason we use for in the perioperative period. So when we administer the drug for regional anesthesia, the drug is placed in the proximity of a nerve where vascularity is very minimal. The drug would ultimately get absorbed into systemic circulation, it would undergo metabolism and would undergo elimination. So that is the way the pharmacokinetics happens. And when the drug is administered intravenously, the pharmacokinetics would differ. So basically, directly the drug is in the circulation in the venous system. Okay, so it would, for example, it will still get bound to the alpha-1 acid glycoprotein, and it will also get bound to the albumin to a lesser extent. And it is carried in this aqueous solution. Blood is taken as an aqueous solution, and it is carried to the system, and it has to come through to the right side of the heart in a concentration which is required to act at the level of the myocardium, okay, through the bloodstream. So the concentration that is reached there at the level of the cardiac cells is the one which is required to produce that particular anti-dysrhythmic effect. Okay, the ventricular tachycardia or the ventricular ectopics, as all of us know, is basically because of the frequent firing from the ventricular ectopic areas. So when we use these agents, the ventricular, the sodium channel blockade is the one which is targeted, and it is apparently going to block the aberrantly firing the ventricular areas and reduce the ventricular ectopics. And subsequently, the continuous infusion is expected to stabilize the membranes. So that's why we call them as sodium channel blockers or membrane stabilizers, whether it is at the level of the nerves in the periphery or at the level of the cells or the myocardium. So membrane stabilization is produced, and the repetitive firing and action potentials are stopped. So this is the first part. And secondly, all of us know, whether it is lignocaine or bupivacaine, at a concentration which we call it based upon a ratio. You've got a CC to CNS ratio, the ratio of the drug to produce cardiovascular collapse to the concentration or the volume required to produce CNS depression. Okay, so either lignocaine also in a higher concentration and bupivacaine in a higher concentration definitely can produce cardiac toxicity. The ratio is on a safer side, approximately 1:7 for lignocaine, and it's about 1:3.4 for bupivacaine. Okay, so you need very high concentrations of lignocaine to produce and precipitate cardiac toxicity, but for producing cardiac toxicity, we need lesser doses, about 1:3.4 for bupivacaine. Okay, so this is based upon the pharmacological studies and pharmacodynamic effects. So when we stick to the dosage recommended to attain the therapeutic concentrations in the bloodstream, it is going to protect the heart. It is not going to harm the conduction from the normal pathways. It is going to reduce aberrant pathway. It is going to promote the normal ventricular conduction and see that there is a restoration of the sinus rhythm. This is the basis of using lignocaine IV as a preservative-free solution for cardiac purposes. And of course, if you talk about the intubation responses, it is a single dose. Okay, it's not going to affect the heart. And we are using for laryngospasm or for mixing with local anesthetic agents. We are not going to expect any overdose effects or toxic effects. I hope this is explanation, sir. Any input? Rakesh, Rajesh, Vijesh? Murthy, sir?
Sir.
You are muted, sir.
I think that explains the answer question.
Please unmute, Doc.
My question: will there be any possibility of why it selectively stop conduction of extrasystoles only? Why it is not reducing the conduction of normal muscle conduction? Normal conduction of the heart, why it is not interfering? Why it is selectively interfering with the ectopic conduction only?
This could be based upon one of my discussions in the early part of the slide. The sodium channels are more frequently open when there is a repetitive firing. I told about that, sir. So, yeah, so more repetitive firing, more frequent action potential generation, more frequent action potential propagation, okay, means more frequently sodium channels are open. And when we say an ectopic and an abnormally firing ectopic, right? I said similarly in the discussion, these are the local anesthetics have preferentially, they go and bind to the open sodium channels, number one. Preferentially, they go to the inactive channels, number two. And number three is a resting channel. Okay, so there is a preference for open sodium channels and the immediately inactivated channels. So obviously, the number of open channels and the number of inactivated channels will be more when there is repetitive firing. So the local anesthetics that is administered like lignocaine here, IV, it is more likely to expected to go and occupy those channels and block the firing, block the creation and propagation of the action potential and reduce the ectopics. This could be a more plausible explanation because based upon my presentations.
Actually, the action potential of nerve fiber is different from the cardiac muscle fiber.
That is true.
Ventricular muscle fiber and the SA node, all are different, AV node.
Yeah.
So it should have a differential action, is it not? The xylocord also.
Yeah. So you are perfectly correct, sir. That's why I said when I went through the literature, there are too many diversions and deviations where multiple factors are involved in the action. I didn't want to basically confuse the PGs further. In the sense, each drug, the way it acts, it doesn't depend upon its potency in terms of octanol buffer quotient. It doesn't just depend upon the dose in terms of concentration and the volume. It doesn't depend upon the PK alone. It also depends upon its affinity. Affinity, each drug is expected to have a different affinity for the sodium channels. The extent of affinity differs between drugs, and the affinity would also determine the time period for which the drug would be bound to that particular receptor. Okay, that's the reason we also talk about bupivacaine, right? We say one example we tell our PGs is, of course, it goes back to the interaction with respect to the action potential. Lignocaine is a fast in and fast out drug, whereas bupivacaine is a fast in and slow out drug with respect to the cardiac system, right? So it produces a continuous membrane stabilization and will precipitate a cardiac toxicity by itself. So that is one mechanism, and it is very perfect, as you say. The action potential voltages would be different for the different conducting system cells and the myocardial cells, right? So it is different in the SCA node and the AV node and the bundle of phase and in the different areas within the left ventricle.
Thank you very much. Wonderful presentation, sir. I appreciate your presentation very much.
Thank you, sir. Thank you, sir.
Thank you, Murthy sir, for the comments. And there is a request, Balavaskar sir, there is a request to explain enantiomers once again.
To explain?
Enantiomers.
Enantiomers. Okay. So you can see this. So basically, it's an advantage. If you can see my video, that itself is like a mirror. So if I show my right hand, I am showing the right hand, but the mirror shows it as a left hand. So all of us have seen this in our daily lives. Okay, this is a mirror image of my right hand, but the mirror is showing this as my left hand. Okay, but still, if I try to approximate this so-called right hand on the mirror with my actual left hand, right? Okay, they say even the most similar objects in the universe cannot be perfectly matched. They may approximate, but there is never a perfect match, right? Even the mirror images are not expected to be matching. So left hand would never be same as the right hand. Even though it's a mirror image, it is shown in the mirror when you hold it in front of the mirror. So this is called a property of chirality. Our hands are chiral. That means right hand is, this is just to explain. If you can see the second image also, there is a molecule. with about 4 atoms, right? So we have shown one hand here. There is a right hand and there is a left hand. Okay, and there is a mirror in between. This is exactly the molecule also. We have shown a molecule on this side and there is a mirror image on the other side. Okay, so this is also a part of the structural differences between compounds with similar atomic weight and similar molecular weight and similar configuration here. If you can see here, the configuration is similar. Okay, I can show with a pen here. See, the configuration of 4 molecules and configuration of 4 molecules. The number is similar. There is a chiral area and they are similar in disposition. But if you see a mirror image, if you see it's in a different plane, the structure is different. So this itself is able to produce a different clinical effect when you use it in a patient, when you use it for some purpose. So this is a principle of the enantiomers. Okay, so they are not superimposable, and I'll go to the next slide here. So I can take a little bit time. I thought people have understood. The chiral structure and its mirror image are referred to as enantiomers. Okay, so this is one enantiomer. This is the second enantiomer. So if I go back to the previous image, this is one enantiomer. It's another enantiomer. So this is a simple explanation. But how is it determined? So if you look at a chiral structure or chiral atom, okay, normally the chiral atom is said to be the carbon. There is an asymmetric carbon or a quaternary nitrogen, which is supposed to be the cause for this chirality for different molecules. Okay, so remember an asymmetric carbon atom, okay, which provides the chiral property to a particular molecule or an agent. Okay, and this chiral property is defined based upon the molecular arrangement. I told you about the 4 dissimilar groups being attached to a carbon atom. So if you see here, if this is taken as a carbon atom, this is a chiral molecule. From here, you look at the 4 dissimilar molecules. So it is G1, G2, G3, and G4. So these are the 4 groups. If I look through this chiral molecule, you will have one molecule with the least molecular weight. Okay, and then you have to track other molecules of increasing molecular weight. So here, if G2 is the one with higher molecular weight, then G3 is one with further higher molecular weight, and G4 is another molecule with the greatest molecular weight. Okay, like this. G1 to G2, there is an increase in molecular weight. G2 to G3, there is an increase in molecular weight. G3 to G4, there is an increase in molecular weight. Okay, there is a clockwise rotation or movement when we track them. Okay, this is called a racemic form or rectus form. It is called R form or rectus form, right? Right. So it is a right form or a clockwise form or a rectus form. If I have it in the reverse direction, okay. So if it is G1 is the least molecular weight, G4 is the least molecular, next higher molecular weight, G3 is the next higher molecular weight, and G2 is the next higher molecular weight. This is called the sinister form or L form. Okay, so we have got an R form or rectus form, and we have got a sinister form or L form, or a clockwise form or a anti-clockwise form, based upon a chiral center that is carbon, through which we look at the 4 other molecules which are dissimilar in terms of the molecular weight. The increasing or ascending molecular weight towards the right side or the clockwise direction is rectus. Towards the left side or anti-clockwise is a sinister form. So these are the 2 enantiomers. We can separate them out. Okay. When you separate them out, they are called enantiopure form. We can have pure or enantiomer form, that is, or enantio pure. We can have a L-enantio pure form also based upon these preparations. They have got similar physico-chemical properties. It is just that that arrangement is different. That will result in the change in conformation of the structure. Change in conformation of the structure would add some biological effect and remove certain biological effect with respect to that particular agent. So I explained with respect to the pipe colloid xylidine preparations. The pipe colloid xylidine preparations are mepivacaine, ropivacaine, and bupivacaine in practice, where this is the chiral center for these drugs, as I told you already, and the different replacements are here. There is a methyl group, there is a ropivacaine, this is a propyl group, and there is a bupivacaine, it's a butyl group. So these will add to formation of different enantiomers also, and you will got different effects. Right? So most importantly, it is made for the R form of the ropivacaine. So R form is, and majority of the local anesthetics which we use regularly, lidocaine, bupivacaine, mepivacaine, everything are enantiomers where we call it as racemate mixtures. There are both R forms and L forms. But over a matter of research, they found, for example, for ropivacaine, they said a R form would be more safe. And in addition, we have got the isomerism, which is also added to different agents. So I think what they can remember is the carbon as a focus or ammonia NH2 group as a focus. Then 4 dissimilar molecules being attached. Look at the molecule with the least molecular weight and look at the direction of increasing the molecular weight in the 4 molecules. So if it is towards the right side, it is the R form or the rectus form. If it is on the left side, it is a sinister form or the L form or the S form. So this will be useful for you to understand the principle. I think you can write this in examination and can get good marks.
Thank you, sir. That explains well about the concept of enantiomers. I think there is no more questions, and we'll go to the next session. This will be in the YouTube, and it will. I think it will be a future reference for the useful future reference for the postgraduates as well as for the practitioners. Any comments, sir?
Yeah, just Dr. Agnihotri sir is raising his hand. You can just, sir, unmute yourself. You can unmute, sir. You are muted. 10 days. You have to unmute, sir.
Dr. Vijesh?
Yeah, I'm here. Sir should unmute by himself. Yeah. He can unmute actually. Sir. Agnihotri sir, please unmute and talk, sir.
Okay. Okay, sorry. Thanks a lot, Dr. Bala. First thing, regarding Sanpiperidine, it was practically researched in the Lucknow by Dr. B.B. Suri, Colonel Brigadier B.P. Suri and Dr. J.J. Lala. And it worked for 3 years. I have worked on that drug, but it was never satisfactory in action because I was very much interested in that. And simultaneously, they have made some muscle relaxant also on the same nomenclature, which was not marketed in that time. This is just for your information. Thank you very much. Nice.
Thank you, sir. Thank you.
Excuse me, Agnihotri sir, that's Sanpiperidine is still available in the market, or are they trying to refine the product?
No, no, sir. No, sir. It is in 1983. It was.
Yeah, it was marketed in 1983.
Yes, and then it disappeared in 1986. I never get up after that.
Because of its safety profile, it was used once very frequently in dental practice.
No. The safety is later on that. There is no actually sustainable action of that thing.
Okay.
The action is bizarre pattern. Sometimes it acts, sometimes it never acts. So we are
Okay.
never sure. Thank you very much.
Thank
I'm
you.
confused with that's a molecular structure. So it's a quinoline derivatives. It's not an ester or amide group.
Yes. Oh,
Quinoline
that much
derivative.
detail I don't know. That's what I told you. Two persons were only the authority on that.
Okay.
Dr. G.J. Lala, late Dr. G.J. Lala, and Dr. B.P. Suri, Brigadier B.P. Suri.
Okay.
You can get the same thesis in the All India Institute because the Dr. Suri was awarded PhD on that topic from Lucknow.
Okay.
Actually,
So what was the name of the muscle relaxant they have come out? The
Same
Central
name,
Drug Research.
same name. Same name.
Senbucridine itself.
Muscle
Okay.
relaxant.
Okay. Thank you, sir.
If
for
you write
sharing this
them, I think you can still get the samples, old samples there.
Okay. Okay. So was the muscle relaxant marketed?
No. It was never marketed.
Okay.
Never.
Okay.
I never.
Okay.
sir, I heard that it has produced paraparesis in 2 patients in All India Institute. That's why the drug has been discarded.
Following spinal
I don't know, Dr. KL, you was working under Dr. Kaul, H.L. Kaul. So both were friends. So he was clinically working at All India Institute and submitted his work in the Lucknow. That much I know as a ISA member. That's all.
Okay. Thank you, sir, for the information.
Thank you.
Now this over to Dr. Vijesh, please.
Thank you, Dr. Rajesh. Before we move on to the next session, I would like to share next week's program. For next week, we have 2 talks. One is on management of brain dead donor, and that will be done by Dr. Radha K.R., who is the professor and head of Department of Anesthesiology, Government Medical College, Calicut. And the second talk would be by Dr. P.M.A. Bashir, who is the additional professor at Government Medical College, Calicut, and it will be on capnography. So kindly do attend next Saturday. We also have an announcement to make on, there is a program that is organized by ISA Thrissur, that is ACT 2021, which is a virtual conference, and it is on 10th of October. So please do attend this program. It's a virtual conference, and it is called as ACT 2021, and it's organized by ISA Thrissur. And for joining the ISA Kerala PG update group, please do send us a WhatsApp message on 90376 Thank you. So we move on to the next session, and the next session is anesthesia for HIPEC, that is hyperthermic intraperitoneal chemotherapy, and this will be delivered by Dr. Rakesh Gar, who is the additional professor at the All India Institute of Medical Sciences, New Delhi. And he has over 250 publications, and he's the editor-in-chief of the Journal of Onco Anesthesiology and Perioperative Medicine, and associate editor of Indian Journal of Anesthesia and Journal of Anesthesiology and Clinical Pharmacology. He was the key author and core committee member for the formulation of the first Indian CPR guidelines under the aegis of IRC and ISA. He also is the core committee member for the formulation of the National Airway Guidelines. And he is the core committee member for the formulation of consensus guidelines for the perioperative management of patients for cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, which happens to be today's topic. So over to Rakesh, sir.
Thank you so much, sir, for the kind, elaborate introduction. And many people are available here who are mentors to me, including Dr. Bala Bhaskar, who has mentored a lot, Dr. Venkat Giri, Dr. Murthy, Dr. Agnihatri, and many senior members. Thank you so much. And also thanks to the ISA Kerala, Dr. MC Rajesh, Dr. Binil, and whole of the executive committee for taking this initiative and bringing this topic of cytoreductive surgery and HIPEC. Now, as it was mentioned in the beginning itself, CRS, cytoreductive surgery are common. They are not very new. It has been done earlier. But the hyperthermic intraperitoneal chemotherapeutic agents administration is again an older modality, but now more and more institutes are taking it up because the cancer is emerging, more onco centers are coming up, and that's why these surgeries are being done. They have different concerns in the perioperative period, so it becomes essential to understand that what those physiological changes happens with this type of interventions, and how can we mitigate them so that the patient outcomes becomes much better. So I'll be taking you through the HIPEC. In fact, HIPEC has been modified or advanced into certain other changes, which includes like HITHOC, PIPEC, and NIPS. So I'll just little touch to them so that sometimes it can come to you in your exams also. Those who are working in onco centers or your surgeons will be asking for it, because now this facility is available at many places, the equipment is available, and it can be done easily. Now, when we talk of the various malignancies, the peritoneal dissemination is considered to be poor prognosis in the earlier days. But if we talk of nowadays, because of the availability of surgical techniques and HIPEC, even this malignancy, which was non-operable, now has an option to provide them option of cure. We also know that peritoneal surface malignancy is present in 10 to 30% of patients at the time of the primary surgery, and the ovarian cancers and colorectal cancers are most common, wherein the peritoneum is included as a part of metastasis or local invasion. The other GI malignancies like carcinoma stomach is also involved in such type of malignancies. And in these malignancies, the option traditionally was palliative, but now cytoreductive surgery combined with perioperative intraperitoneal chemotherapy is a valid treatment in these group of selected patients. Now, what exactly we do in this surgical procedure is, basically there are 3 stages for it. And the first stage is the exploration. Usually the surgeon starts with exploratory laparoscopy, usually along with the outcome on imaging, and they assess for the disease progression, or they want to just assess the disease presence into the abdomen. And then they take a decision whether it is operable for this type of surgeries or not, and then take a decision. Sometimes it is directly done open based on the imaging modality. So once it is explored and it's doable, then the cytoreduction is done. Herein, the surgeon removes the visible macroscopic tumor because the tumor is extensive. They cannot be removed totally. If they try to remove it totally, the whole abdomen will be devoid of any organs, and it is absolutely not justifiable. Herein, they will remove certain organs, debulk the macroscopic tumor, and whatever the microscopic tumor seedlings are left, they are taken care of by chemoperfusion, and this is what is HIPEC. Herein, the abdominal cavity is rinsed with a heated chemotherapy solution for variable duration, 30 minutes to 90 minutes, along with chemotherapy which is heated. And this chemotherapy, heated chemotherapy, will act on the microscopic seedlings which have remained after the cytoreduction, and that's why the outcome becomes better. So this is the whole process, and we'll discuss that how this whole process has an implication in a perioperative care. So when we talk of cytoreductive surgeries, it is a major surgical procedure which includes total peritonectomy and along with visceral resection depending upon the extent of tumor. The total peritonectomy means total omentectomy, anterior and lateral parietal peritonectomy, pelvic peritonectomy, subdiaphragmatic peritonectomy. So total peritoneum is removed along with the falciparum and gastrohepatic ligament and parts of mesentery which is involved. With regards to the visceral resection, depending upon the site and involvement of the organs, at times spleen, gallbladder, rectosigmoid GI structure, uterus and ovary, appendix, small intestine part of colon is removed. So that's why it's an extensive surgery with huge amount of pain, with huge amount of fluid shift, blood loss, and so on and so forth. The HIPEC was initially started by Paul Sugarbaker, and wherein he tried to treat patients of peritoneal mesothelioma by applying the heated chemotherapy directly into the stomach after removing the visible tumors. Now, when we talk of the malignancy that I just mentioned, the ovarian, the GI malignancy, and the primary peritoneal tumors, These are the majority of them where the peritoneal carcinomatosis can happen. But then apart from this, we should be very careful that the preoperative assessment surgeons do. There is no extra abdominal metastasis. But even nowadays, it has been combined with high torque. This means even sometimes if the pleura or the diaphragmatic pleura is involved, or there is there is parietal nodules into the thoracic cavity, a combined approach is done. So even though it has been extended very recently, last couple of months, last couple of years, but there should be high probability of complete macroscopic surgical resection. Like for example, say caking of abdomen. If the abdomen is fully frozen, then obviously this type of surgical procedure is not applicable, and that's why they do a laparoscopy to assess these patients preoperatively. Now, patient selection is usually based on patient assessment, the good performance status, the favorable biology, that is the chemosensitive tumors, usually age less than 70 years, absence of extra-abdominal disease, absence of parenchymal liver disease and retroperitoneal nodes. Optimal cytoreduction is visible. Cytoreduction means when we say the all visible tumor are resected to an extent that less than 2.5 mm nodules are left into the abdomen. Satisfactory organ functions and no active cardiac condition. Usually for elderly patients with multiple comorbidities who are having distant metastatic disease with massive retroperitoneal lymph nodes because the perfusion cannot happen at this site, and the involvement of major organs which cannot be removed, or PCI, which is peritoneal carcinomatosis index, which I'll show you a little later, is more than 20. These are not the suitable candidates for this type of surgical procedure. And this is what we talk of PCI, which is usually done. It all depends upon the involvement of the tumor at various areas. It is divided into various segments, and then based on the tumor size, the calculation is done as shown in this chart. And based on this, the total PCI score is calculated. If less than 420, it is taken as curative for the purpose of CRS HIPEC. More than 420, usually it's a big issue because the cytoreduction is not possible and the surgery is not practically feasible. Now, what the rationale of this combined approach is, which I just mentioned, to summarize it once more. When there is a peritoneal surface malignancy, there would be a macroscopic disease and a microscopic disease. Macroscopic disease is taken care by the surgical, that is cytoreduction, and microscopic disease will be taken care by HIPEC. That's why disease eradication or the tumor cells are taken care of, and this is what is supposed to improve the outcome from the surgical point of view, the oncology point of view, and hence this combination has been found to be important. And why addition of HIPEC? Why are not we considering to just give systemic chemotherapy? Why systemic chemotherapy is not amenable to treat these patients when they have a high tumor load? So the pharmacokinetic advantage of intraperitoneal chemotherapy are many. So when there is a tumor mass in the abdomen, at times the vascularity of that tumor is not very good. So even if we give a chemotherapy systematically, the perfusion of chemotherapy into the tumor cells may not happen. And that's why the tumor eradication may not be successful by giving systemic chemotherapy. But when we give it intra-abdominal chemotherapy, the exposure of the poor vascularized tumoral cells to high concentration, direct contact of these high concentration of cytotoxic agents increases the effect on the tumor cells and hence their eradication. The direct contact of higher concentration, which is almost 75 to 1000 times greater, which cannot be given systematically because of high toxicity, but can be given abdominally in HIPEC, and hence the effect is much better. Tissue penetration is much better. And to increase it further, it is heated one. That's why it's called heated intraperitoneal chemotherapy. So thermal enhancement of cytotoxicity happens because the heat synergizes and potentiates the effect of chemotherapeutic drugs. Hyperthermia also reduces the cellular resistance to various chemotherapeutic agents. Cisplatin is one of them. And cells becomes more chemosensitive, and it's primarily because of the metabolic effect of hyperthermia. And that's why the effect of chemotherapy on these cells are much, much better. And that's why the absorption of the chemotherapy, direct chemotherapy inside the tumor cells is better, and hence the eradication happens. But we need to remember that the penetration of drugs can happen just by 3 to 6 mm when they're heated one. And that's why we said the macroscopic tumors should be removed first, and only the microscopic tumors, which is usually say less than 2.5 mm, is considered for a HIPEC. If it is a big tumor which is not can be cytodeductively removed, they are not taken for HIPEC surgical procedures. So it becomes essential to have optimal cytodeductive surgery before the HIPEC procedure is started. This is what actually happens. So when we say even the chemotherapeutic agents who are high molecular weight, when they are administered, they may not be penetrating and crossing this barrier. But when you are giving intraperitoneally, they have a high exposure in an appropriate concentration, and the absorption is not there, and they don't have a systemic toxicity, and that's why the effect is much better. This is how the hyperthermia kills the tumor cells. The HIPEC, the chemotherapy is heated through a specialized equipment to 41 to 43 degrees Celsius. And what it does is it inhibits the RNA synthesis in the tumor cells, causes mitosis arrest and cell death. Other mechanisms are increased lysosomal activity in malignant cells that leads to self-destruction. Also, it causes vascular stasis, anaerobic glycolysis, lactic acidosis, which again induce lysosome, leading to cell death. And again, this vascular stasis is expedited by the inhibition of oxidative metabolism because of hyperthermia and chemotherapy effect. And this is how the whole function works. Now, when this patient is being operated, this cytoreduction is done. This is the specialized machine through which the heated chemotherapeutic agent is circulated into the abdominal cavity through a roller pump. And this continues for variable duration. The temperature is kept between 41 to 43 degrees Celsius. And this rotation of chemotherapy to maintain this temperature happens continuously. And this is given usually 60 minutes, but depending upon the indication, it can be from 30 to 90 minutes. The HIPEC drugs that are used, the chemotherapeutic drugs that are used, they should have well-established activity. They should lack severe direct local toxicity. So these are the ideal characteristic of the various drugs that we use. And the standard dosing is by body surface area. And they are usually given into a carrier solution. And most commonly, the carrier solution is dextrose solution. This means when the fluid is being circulated, as I mentioned here, it has to be circulated into some fluid. So drugs like cisplatin, oxaliplatin are diluted into 1.5% dextrose isotonic peritoneal dialysis solution, and they are circulated in the abdominal cavity for variable durations. Now, these are the various drugs that are being used for intraperitoneal chemotherapy. More commonly are cisplatin, oxaliplatin, mitomycin. But at times, the other drugs like carboplatin, doxorubicin, paclitaxel, docetaxel, and 5-fluorouracil are also used. This all depends upon the type of malignancy, and accordingly, the dose and the drug are used. This is the HIPEC machine that is being used. You can see that the temperature is being maintained. This is the timer here. These are the roller pumps, and these are tubings which circulates the fluids into the peritoneal cavity, as you can see in these diagrams. Now, these circulation can be done via various options. It could be an open abdominal technique, closed abdomen technique, PC peritoneal cavity expanders, and it could be semi-closed technique. So like this is a semi-closed technique, this is closed technique. Sometimes this is again a closed, this is a semi-closed technique. And sometimes an expander is put so that a space is created inside the abdomen for the circulation of the chemotherapy. And this is what is called as peritoneal cavity expander. Now, in the open abdominal technique, a specialized catheter, which is called Teknoff catheter, and 4 closed section drains are placed through the abdominal cavity, as you can see here. The roller pumps, which I showed you in the earlier picture, they forces the chemotherapy into the abdomen, and they are rotated, and they are heated by the machine so that temperature is maintained, and flow rate is usually kept around 1 liter per minute. So it's a high flow. Heat exchanger in the machine keeps the fluid at around 43 degrees Celsius so that the temperature at the abdominal cavity is maintained at the same time, because the circulation is happening and reheating is happening. The advantage of this technique is this is when the abdomen is open, the fluid can be seen circulating into the abdomen appropriately. But the drawbacks are, because the abdomen is open, the heat dissipation happens. We want hyperthermia, but heat dissipation will happen. Chemotherapy can have some inhalation exposure. They can vaporize and cause the healthcare exposures. And it can also lead to a risk of spillage. And that is, again, toxic to the surgeons and anesthesiologists. Now, this is a closed abdomen technique in which after cytoreduction surgery, catheters are put and the abdomen is closed. And then through these catheters, the chemotherapy agents are circulated into the abdominal cavity using the roller pumps. And after the chemotherapy has been circulated for 30 to 90 minutes, the abdomen is again opened up. Final anastomosis of the bowel or organs are done, and the catheters are removed. Advantage, hypothermia is achieved because abdomen is closed, so there is minimal heat loss. Contact is better. And also the healthcare personnel are not exposed to the vaporization of chemotherapeutic agents or the spillage. But the issue is, because the abdomen is closed, the bowel is tightly packed, the abdominal organs are tightly packed. At times, the circulation of the chemotherapy into the abdomen is not uniform. There could be some site in the abdomen because you are not able to see directly. So there could be some site which is not having appropriate concentration or exposure of the chemotherapeutic agents. Now, this is peritoneal cavity expanders that are usually put here. These are variations of open technique wherein an acrylic cylinder containing inflow and outflow catheter that is secured over the wound. They are lifted up and abdominal cavity is created, in which again the hyperthermic chemotherapy is circulated. Semi-closed technique, the abdominal wall is suspended by a self-retaining retractor, and it is covered by cellophane or some sterile tissues, and then using the some amount of sometimes equipment or sometimes even the hands, plastic hands covered with appropriate gloves can be used for helping in appropriate circulation of the hyperthermic chemotherapy into the abdomen. Now, this is just to summarize what I have said till now. So what happens in the CRS HIPEC procedure? We assess the patient first, then do the cytoreductive surgery, then do the HIPEC procedures, then do the reconstruction. Now, this is important here. When they do a cytoreductive surgery, they must have done hemicolectomy or they have done bowel resection. The anastomosis is not done because even those anastomotic sites may have tumor and they can have recurrence thereof. So once the tumor have been removed, the organs have been removed, they are not anastomosed, they are not reconstructed. They are having HIPEC first, and once the whole exposure of the organs happen, then the reconstruction starts. And depending upon the patient situation, they are taken care in the intensive care unit for postoperative monitoring and management. So what we require a very holistic assessment and probably a prehabilitation and optimization of the associated condition and prehabilitation with regards to physiotherapy, nutritional, lung recruitment, and so on and so forth. Intraoperatively, I just mentioned, and they require intensive care in the postoperative period. So let's move with the preoperative considerations. So now in this situation, usually these surgeries are high-risk procedures, so we always look for the ASA physical status for these patients. Try to optimize the comorbidities because there will be a lot of respiratory, cardiac, and renal perturbations in the perioperative period, and hence if they have associated comorbidities, they need to be optimized. Also, we need to assess because these patients would have received preoperative chemotherapy, so we need to look for the chemotoxicity and whether they have recovered or not. Also, try to identify various nutritional status, and albumin is one of the important marker. Albumin less than 3 grams per deciliter is considered to be an independent predictor of poor outcome. And the prehabilitation in the form of respiratory recruitments and the nutritional, they are taken care of. And patients are also explained about the major surgeries, the creation of stroma, they are counseled about the marking and all and so forth. When we talk of these patients in the preoperative period, a large abdominal mass for long duration, they can have a lot of respiratory function compromise. They can have ascites, they can have pleural effusion, they can have basal atelectasis, diaphragmatic splinting, decreased FRC. And that's why these patients need to be assessed for this. At times, you can take care of it. But usually we don't tap for pleural effusion. Ascites, we don't tap preoperatively because it can lead to seedling of tumors. And that's why these patients do have respiratory compromise. The CVS compromise can be because of the disease status itself, or because of the associated pre-existing comorbidity, or it can be related to the effect of chemotherapeutic agent. We should be careful about the pain management. Some of these patients do have preoperative pain. They may be on some analgesics. Being a major surgical procedure, you should have a pain management plan, needs to be discussed with the patient. The coagulation abnormalities can happen in these patients. These patients may be preoperatively on chemotherapy. So chemotherapy, bone marrow suppression can happen, and coagulation abnormality can happen. And also, being a long procedure, a good amount of fluid shift, blood transfusion, chemotherapy side effects can also lead to this coagulopathy in a perioperative care. Renal function electrolyte imbalance can happen because of chemotherapy toxicity. They can have a risk of acute kidney injury because they are being provided chemotherapy which is heated. So both things can affect the kidney function, and they can have acute kidney injury in the perioperative period. And that's why you need to assess the renal functions preoperatively. The abdominal distension can happen. The organ compromise can happen. They can be at the risk of regurgitation and aspiration. So you should be cautious about the preoperative aspiration prophylaxis in these patients. Being a major surgery, they may not be operable at all time. There could be residual tumor. So please do counsel the patient about the quality of life, because being a major surgical procedure, there are associated comorbidities. There are associated a lot of like stroma formation and so on and so forth. They usually have multi-system involvement because of the major surgical procedure. There could be removal of spleen, there could be partial hepatectomy, there are removal of small bowel, large bowel, and that's why you need to be cautious about impact of this in the post-operative period. These patients remain at high risk of DVT, and hence prophylaxis needs to be started at appropriate time. We usually start them pre-operatively and also continues in the post-operative period. Intraoperatively, we usually keep them on mechanical prophylaxis using a DVT pump. Coming to the intraoperatively concerns, these patients are positioned into a lithotomy position, and that's why the positioning should be done appropriately. There can be issues because of the temperature changes, as we see that during the procedure, they are being heated at 42 to 43 degrees Celsius. So temperature would change. You can see here, when we start the case, the temperature is usually around 37, but with the CRS, good amount of fluid shift happen, fluid resuscitation, blood loss, temperature comes down. And when we start hypothermia, the temperature starts coming up. Sometimes even it reaches 40 degrees Celsius, and that becomes an issue because it will cause a lot of coagulation, metabolic homeostasis, anti-inflammatory cascade, and neurological status all will be affected because of this thermal changes. And the temperature fluctuates. So this fluctuation also has an impact. In cytoreductive phase, there is risk of hypothermia. So that's why we use forced air warming with blankets and use warm solutions. We need to remember it comes sometime when hypothermia is supposed to happen. Why not to allow the hypothermia to happen in the cytoreductive phase? No, it causes a lot of issues. Any temperature fluctuation will lead to issues. So that's why in CRS phase, we take all measures to prevent hypothermia. In HIPEC phase, hypothermia happens, which can lead to a lot of specifically the cardiovascular abnormalities, metabolic changes. It includes peripheral vasodilation, increased metabolic rate, increased oxygen demand, increased heart rate, increased production of carbon dioxide. It also causes a good amount of increased lactate. Sometimes it reaches as high as 5, 6, 7 in spite of appropriate resuscitation. Post-HIPEC phase, all this temperature fluctuation, we have to come back to normothermia. And that's why just to maintain it during the HIPEC phase, we use appropriate monitor. We switch off forced air warmers, we start cooled infusions. And depending upon the carbon dioxide levels, the ventilation strategies are kept, and lactic acids are taken care of by serial measurements with appropriate fluid resuscitation. They usually come down in the post-operative period. The monitoring should be appropriate for management of temperature during CRS and HIPEC. We usually monitor core body temperature. For fluid, we use fluid warmer infusers, warming blankets. The operating room temperature is optimally kept. And we also monitor the temperature of the perfusate. Sometimes the perfusate temperature can go up 45, 46. If the patient's temperature is rising, we try to decrease it to 41 and 42. Now, we also need to look for the fluid administration, which again differs in various phases, including the CRS and HIPEC phase and the postoperative care. When you talk about the fluid management in CRS phase, a good amount of fluid losses happens because of extensive debulking and extensive surface exposure. Because of ascites, a good amount of protein loss also happens. Herein, we try to give them an appropriate fluid with some goal-directed therapy so as to have a urine output of 0.5 mils per kg per hour. HIPEC phase in a hyperdynamic state, there is a lot of cardiovascular metabolic changes happening. The kidney function is compromised because of direct hyperthermia and chemotherapy. And that's why at this point of time, we have to chase for the urine output to little higher of 2 to 4 ml per kg per hour. And a goal-directed fluid therapy, usually we use a cardiac output monitor that helps us. In the post-HIPEC phase, the increased amount of oozing can happen because of the various extensive dissection. And that's why we supplement them around 100 to 200 ml, depending upon the cardiovascular status, so as to maintain a urine output of 1 to 2 ml per kg per hour. The post-operative fluid balance is again challenging, and though the requirement comes down, because whatever the fluid which are coming from the generalized oozing, because extensive debulking has been done, so there will be some amount of oozing which may be a little higher in protein also, and hence we need to supplement them accordingly and give the fluid accordingly. The type of fluid is a challenge, whether we should use crystalloid or colloid. There are a lot of controversy. We don't have a very strong evidence for it, especially with regards to the use of colloids. But however, the balanced salt solution, balanced fluid management is the use of crystalloids, followed by colloids if required, because there is good amount of protein lost during the surgical procedure because of extensive tissue handling and cytoreduction, along with the drainage of ascites in these patients. The hemodynamic changes do fluctuates during the CRS because of blood loss. The BP comes down, the heart rate probably increases. During the HIPEC phase, it's in hybridynamic state, so there will be an increase in heart rate, means CVP, the pulmonary artery pressure, the vest pressure, the cardiac index, all tends to increase up. And after the HIPEC phase is over, they try to stabilize after the HIPEC phase is over, when the temperature and other parameters try to come down normal. The respiratory changes are primarily because initially patient has a lot of abdominal mass. So there will be, as I mentioned earlier, a splinting, decrease of RC, basal arterial excesses. Similar will happen during the HIPEC phase also, because the abdomen is stressed and it is being filled with the hyperthermic solution which rotates. So again, it will cause increase in the intra-abdominal pressure, cranial shift of the diaphragm, leading to respiratory compromise, high airway pressures, basal arterial excesses. So this will happen in these patients. That's why we see, and even also the metabolism is increased. So there is increased production of carbon dioxide also. The implication for us during this phase is usually we increase the minute ventilation during the HIPEC phase to normalize the carbon dioxide levels. We do serial ABGs every 15 minutes during the HIPEC phase, which gives an appropriate indication of the adequacy of ventilation and oxygenation. And usually if you see on this chart, during the HIPEC phase, it starts increasing and then it starts coming down after the HIPEC phase when the body metabolism try to become normal. With regards to the electrolyte and glycemic disturbances, a lot of electrolyte imbalances happen. There will be change in the calcium, potassium, sodium, magnesium. After surgery, the hypocalcemia and hypomagnesemia and lower sodium levels are usually seen. Because of the extensive surgeries, potassium levels can rise at some point of time. The hyperglycemia and hyponatremia can also happen because of perfusate, especially with 5% dextrose solution is used as a carrier for chemotherapeutic drugs like oxaliplatin. With regards to renal changes, the systemic hypoperfusion because of the third species loss, because of the extensive surgical blood loss, these patients can have systemic hypoperfusion, and that can lead to decreased renal perfusion. Chemotherapeutic agents like mitomycin C and cisplatin can aggravate nephrotoxicity because they are nephrotoxic drugs. And the role of low-dose dopamine and furosemide, as we all know, is having not any role in preventing the renal compromise in this surgery, so they are not recommended. And we should be careful. That's why, because of these renal changes, we should be careful for assessing their kidney metabolic changes. There will be a lot of changes in the lactate levels, as you can see in this graph. With this surgery, extensive surgery, increased metabolism. During the HIPEC phase, the lactate levels rises. Sometimes it can even reach to 6 to 7. And then after adequate hydration and resuscitation, it starts coming down. The base excess is on a negative side. The pH starts decreasing because of all those metabolic changes. And these do have an impact on the cardiovascular system by causing more of a cardiac compromise situation by hypertension and tachycardia. And this is well known. The lactate levels we monitor very regularly in the intraoperative period and even in the postoperative period, because it is a very good predictor of the morbidity, mortality, and survival in patients undergoing CRS and HIPEC surgeries. So that's why you should be looking for the lactate levels, and your management, especially the fluid management, should be accordingly done. These patients can have coagulation abnormalities because of various reasons: hypoproteinemia, hyperthermia, impact on the chemotherapy, intraoperatively and preoperative chemotherapy, massive fluid shift, fluid resuscitation, causing dilutional coagulopathies. And also these patients are usually nutritionally poor. And that's why a coagulopathy can happen. Usually these manifest in the post-operative period on usually day or 1 or 2, and then try to stabilize in coming days when they are appropriately resuscitated. And that's why you should be monitoring for the coagulation parameters appropriately, because sometimes we are putting regional blocks so that we also start them on DVT prophylaxis. So you should be very careful about these coagulation abnormalities in the perioperative period. And usually, most of them, the conventional tests like the platelet counts, the PT, APTT are sufficient. But at times, for major surgical procedures with pre-existing some disease, we also use the point-of-care coagulation testing like thromboelastogram or rotational thromboelastometry. Preoperative investigations, apart from routine investigations, these patients, depending upon individual cases, we require CPET, which is cardiopulmonary exercise testing, which give a very comprehensive assessment of these patients from the cardiovascular and respiratory status. And some of these patients do require echocardiography depending upon any cardiac comorbidity or because of the effect of chemotherapeutic drugs on the cardiac function preoperatively. In those situations, echo or a stress echo may be required. The monitoring that we require for these patients is as per the patient assessment, and we go for, apart from routine monitoring, we try to arrange for CVP, arterial line, cardiac output monitor, temperature probe, urine output monitoring, and in selected cases, point of care testing using thromboelastogram or ROTEM. For monitoring all those monitors, we have to arrange for pulse oximeter, capnograph. We do use oxygen and gas analyzers. These are very important in these patients. We do look for the neuromuscular monitoring because long surgical procedures, effect of chemotherapy, the metabolic abnormalities. So all this can lead to various issues in the neuromuscular function, especially at the recovery. So we use neuromuscular monitoring also. Though we use, we do insert the central venous pressure, but it's not a very good indicator of the fluid status, and that's why they are not very good as a reliable indicator for fluid resuscitation. And the more invasive techniques like Schwann Cells are not indicated, but there is an emerging role of other monitoring. But then with the emergence of non-invasive cardiac output monitor, they are becoming more popular as compared to the transesophageal echocardiography. These patients, because of the abdominal distension, these patients do require rapid sequence induction and intubation. Being a major surgical procedures, regional anesthesia is usually given. A combined spinal epidural along with GA, or maybe epidural with GA is given. But yes, sometimes they have coagulation abnormality. In this, we avoid regional anesthesia as it could be risky. It can lead to epidural hematoma. In those situations, we do give them PCA, patient-controlled analgesia, in the post-operative period. The invasive monitoring is essentially required for fluid management. The temperature monitoring is required for good perioperative thermoregulation, and electrolyte imbalances should be monitored and corrected as appropriate. As I mentioned earlier, because abdomen in the preoperative period, but also in the intraoperative period, because of perfusate, they can lead to increased abdominal space, leading to compromise of the respiratory organ. Analgesia is essential. Positioning can also, because it's a lithotomy position, again, this can affect and it should be taken care of. And various inflammatory markers can affect. The coagulation should be observed. The metabolic components should be monitored using serial ABG monitoring. Looking for the electrolyte abnormality and correction. DVT prophylaxis should be given. Major surgical procedure as per your antibiotic policy, antibiotics are administered. For pain management, we usually use multimodal approach for these patients. IV analgesics usually includes opiates. Try to avoid NSAIDs because they can cause coagulation abnormalities, but acetaminophen, paracetamol can be used. We do give them intrathecal opiates because it's a wonderful drug and it gives a long-lasting, reliable pain management in these patients. The thoracic epidural has its own advantage. We are using it, but sometimes because of the coagulation abnormalities, it can lead to issues. Also at times, especially when we are using local anesthetic agents because of sympathetic blockade, hemodynamic instability will be much more. But yes, however, it gives a good control. These patients do require a very, very a place where they can be monitored for any conditions that can happen after this medical surgical procedure, including metabolic disturbances, cardiovascular disturbances, respiratory disturbances, and hence it requires a very monitored care in the post-operative care with regards to wound management, wound care, nutrition, early mobilization, respiratory care, and cardiovascular status. In these, the fluid losses usually continues for 1 to 3 days, and that's why your fluid resuscitation should be appropriate, especially on the background that a possible direct renal injury could have happened, and hence a good renal perfusion should be maintained. There is good amount of oozing from the various raw surfaces because of cytoreduction, and hence they lose a lot of fluid from the abdominal drains, and hence needs to be looked for. These patients can have a lot of abnormalities, a lot of complications, and hence needs to be identified because they undergoes complex surgical procedure. There could be wound infection, there could be bowel perforation, there could be hematological toxicity because of the direct toxicity effect of the chemotherapeutic agents. The respiratory compromise can happen. Sometimes we find that the reactive pleural effusion happens in these patients. Sometimes because of the peritoneal removal, there could be diaphragmatic injuries, which are sometimes not identified. And when patient starts having spontaneous respiration, they manifest pneumothorax. And there could be issues with the embolism and cardiac failure because of the direct side effect of the chemotherapeutic agents, or also because of the long surgical procedure. In the post-operative, you should be cautious about the fluid and hemodynamics, should cautious about coagulation parameters, monitor the electrolyte imbalance, analgesia, look for the stress assessor prophylaxis, and thromboprophylaxis needs to be continued in the post-operative period. We need to start them on feeding appropriately because they promote wound healing and improve intestinal transit. Usually, the preference would be for enteral nutrition, but sometimes, depending upon the surgical procedure, they may require parenteral nutrition also. Depending upon the intraoperatively hemodynamic instability or respiratory compromise or cardiovascular compromise, they may be on mechanical ventilation for a couple of hours to a day, and then they need to be weaned off as early as possible. And majority of patients we are able to wean by day 1. Being an extensive surgery, the bone marrow suppressive effect of the chemotherapeutic agent, these patients can have leukopenia, and the risk of infections are high. So we should follow utmost aseptic precautions for various interventions like CVP line insertion, epidural catheter insertion, and so on and so forth. Look for the renal status, the glycemic control in these patients, as it could have been affected intraoperatively. Patients are started ambulatory as early as possible. Majority of our patients are ambulated on day 1, and that's why they become more comfortable by having recruitment of various organs and they feel better. Stoma care needs to be given. Having said that, the OT personnel should also be take care of them because they are directly exposed to the chemotherapeutic agents. Heated one, they can vaporize, they can contaminate the environment. Sometimes these chemotherapeutic agents can spill while the fluid is being circulated, and hence all precautions should be taken up by the OT personnel, including surgeons and anesthesiologists and other staff, so that they are not exposed to these drugs. We have good guidelines which are published regarding HIPEC, and the ERAS protocols that are applicable for other surgical procedures are also applicable for CRS and HIPEC. I'll not be going into detail in this, but I will just leave it to you to look for these articles which are published last year in the European Journal of Surgical Oncology. And these are wonderful guidelines where they have mentioned various ERAS protocols in the preoperative period and the post-operative period, and they have been found to increase the quality of life and better improvement with less morbidity and mortality in these patients. And they include rehabilitation of these patients, prehabilitation of these patients, and taking care of various aspects. So these can be read from this article, which is a wonderful article, and I will suggest everybody to go through it. So a little bit of, I said HIPEC, which is intraperitoneal. Nowadays, similar procedure is done for HITOC, that is for pleural tumors now. So this is an intrathoracic chemotherapy perfusion, and sometimes it is done simultaneously when the pleura is involved along with the abdominal organs. So sometimes they do a combined procedure. It's again a very challenging procedures wherein thoracotomy is done, or from the abdominal approach, the pleura is removed, the diaphragm is removed, and then they remove the tumor and do a combined procedure of HIPEC and HITOC like this. You can see here, the whole structures are removed, the thoracic cavity, the pneumonectomy has been done, and then they perfuse the heated chemotherapy in the abdomen along with the thoracic cavity, and then they reconstruct, putting up various meshes. So this is how it has been done in the thoracic cavity using an open technique. For this HITOC, there is a lot of, because we are instilling the hyperthermic agents directly into the thoracic cavity, which is in touch with lungs as well as the various major vessels and the cardiac tissue. So this cause a lot of CVS and respiratory compromise, and that's why we should be very, very cautious. We don't have an option not to say no, because we know that this will cause hyperthermic changes. This will cause direct toxicity to the heart. There will be a lot of arrhythmias happening, and that's why we should be conscious about it and try to take care of them. It requires a lot of understanding, good amount of fluid therapy, careful filling of the thoracic side, early use of catecholamines to decrease the sensitivity of the direct injury to the lungs needs to be taken care of. So we have already published this combined therapy, which is combined HIPEC and HITEC in this article. So more details can be seen in this article also. And they have, as I mentioned about the HIPEC, in the HITOC, along with all those abnormalities, there will be direct issues with the major vessels as well as the respiratory status. The other procedure which is in sync is the PIPEC. Now, in the HIPEC, we are giving the hyperthermic chemotherapeutic agent as a fluid, but here they are aerosolized, and this pressurized aerosolized is circulated into the thoracic cavity. This is called PIPEC. This is usually given for those patients who are a little sicker, who cannot tolerate it. So we give them high aerosolized chemotherapeutic agents. So the chances of outcome becomes much better in these patients. This causes a little less amount of complications. So that's why they have been used in high-risk patients. And in PIPEC, what we do is, after giving general anesthesia, a capnoperitoneum is created. Once the capnoperitoneum is created, the biopsy is taken, and then a pump is connected to the IV, high pressure injector, and this pressurized aerosol is injected into the abdomen and circulated, and this takes care of the direct aerosolized chemotherapy into the abdomen. And this is how this PIPEC procedure is done, wherein the high pressure line and pump is injected into the abdomen using a laparoscopic carbon dioxide insufflator. So this is what actually happens. The flow goes from one side, it comes from other side. You see the organs, the pressurized aerosolized chemotherapy circulates in the abdomen, and probably it will take care of the chemotherapeutic agent. And this is the open procedure. You can see a laparoscopic arm here, and the aerosolized procedure is being circulated into the abdomen based on this. Now, the other procedure is HIPEC, which is again sometimes when the patient becomes a lot of intraoperatively hemodynamic unstable. So we just don't go for the HIPEC here. In post-operative period, we just put the drains, and this drain is circulated the normal temperature chemotherapy for 5 days, 3 to 5 days. They are circulated in the abdomen for a couple of hours, and then it is drained out, and then another cycle starts. And this usually continues for around 3 to 5 days, so that this again gives direct chemotherapeutic effect on the residual tumor. And this is how this is almost similar like you do the peritoneal dialysis. So the arrangement appears to be similar to it, and you can give it, especially when those patients who are not tolerate HIPEC because of hemodynamic instability, we give them EPIC in the post-operative procedure. Now, this is again another challenging tool which is coming in. Now, this is what is NIPS. Herein, we just not give the HIPEC, we also simultaneously give the systemic chemotherapy. So we are acting from both the sides. Systemic chemotherapy, perfusion, vascularity, take care of the tumor. And simultaneously the intraperitoneal chemotherapy. So this is again the emerging procedure which is being done, just started. This is one of the emerging procedure. So probably it will come up in real practice. And again, I think anesthesiologists will have more challenge because it's just not HIPEC, we are getting new and new procedures. The Society of Onco-Anesthesia and Perioperative Care has provided the guidelines. I think this is one of the good articles from India itself. So I'll request that you can go ahead and see this article where how to manage a case of CRS HIPEC has been mentioned through various evidences, and the recommendation through various phases of surgery has been described here. To summarize, CRS and HIPEC requires thorough assessment of patients and attempt for optimization, including prehabilitation should be done in these patients. CRS is a complex surgical technique, and CRS HIPEC causes various physiological changes. So that needs to be understood for creating a plan. The cardiovascular changes, the respiratory changes, the fluid shift, the electrolyte imbalance, the coagulation, the hyperthermic effect, the effect of chemotherapeutic agent, the effect of hyperthermia, all those needs to be understood and accordingly managed. Goal-directed fluid therapy appears to be an accepted technique. Use of minimally invasive technique like cardiac output monitors are good. And we should also be taking care of their immediate post-operative care because these patients would manifest various hemodynamic and respiratory compromise in the post-operative period, especially for 1 to 2 days, and hence require extensive monitoring in a critical care setup. Thank you so much.
Thank you, Rakesh sir, for that comprehensive presentation and for enlightening us on the various modalities through which we can administer chemotherapeutic agents. Thank you once again, and the talk is open for comments and queries from the attending faculty and postgraduate students. Sir, any special any special masks to prevent this? Do you use PPE and all that during this procedure?
No, yeah. So for the purpose of this specific PPE is not used. So usually we use either a double triple layer mask or N95 mask for this. So those masks are available, and we maintain a safe distance while the HIPEC is going on. The surgeons usually wear a face shield because they are almost in the vicinity of it. So they wear a face shield along with the N95 mask. They do wear double gloves, and the gloves are till elbows because direct when they are using the chemotherapeutic agent, they can fall on it. And the kit or the gowns they are using is impermeable, so that they take care of it. And during the HIPEC phase, we keep minimum number of people inside because surgery is not going on. So we keep minimum people of it. So usually there will be 1 or 2 surgeons, and the anesthesiologist is more important because they cannot go out because this is a typical phase. So surgeons are resting and the anesthesiologists are on the toes, but we maintain a safe distance, taking care of that spillage, and the aerosol inhalation does not happen.
So do the blood levels go up when it gets absorbed from the peritoneum as well as the pleura? These drugs can get absorbed.
Right. Some amount of drugs is absorbed, but it has been seen from various evidences, and we have seen and almost getting more than around 300 cases done at our center over the last couple of years. The systemic toxicity is usually not seen in the majority of these patients because the systemic absorption is much less. Though we are using a higher concentration, the concentration at the level of peritoneum chemotherapy tumor interface is very high, almost more than 75 times as compared to systemic. But still the systemic absorption is not too much. But yes, some amount will happen because hyperthermia increases vascularity. And since the raw surface, because of the CRS has already happened, some systemic absorption happens, and there would be some side effect in the post-operative period. Sometimes the counts come down, they are at risk of infection, they have increased amount of metabolic acidosis, renal toxicity can be seen, and that is why we give a good amount of hydration, maintaining a good urine output, so that whatever the toxicity is happening, we are able to mitigate them through these conservative measurements that I just mentioned in my slides also.
Thank you, sir.
Dr. Rakesh, to what extent do you allow the fluid temperature to rise, the perfusated fluid to rise, 42 or 43 degrees centigrade?
So we usually keep around 42. So we expect, we keep the set temperature on the machine as 42 to 44 degrees Celsius. So when we keep 44, it usually the temperature at the body is usually around 41 to 42. This is the standard setting. But we also monitor the temperature of the patient. So till 37, 37.5, 38, it's not a big issue. We are able to manage it using cold fluids, keeping the bear hugger on an ambient temperature with breeze of air. We are able to manage it. But in case in 1 or 2 patients, we have seen that it has gone up to 39 and 40. In those situations, we decrease the temperature of HIPEC a little lower and then continue the procedure. So otherwise, we keep around 42 to 44, 44 at machine, 42 at patient.
So when this happens, occasionally we use that dialysis machine. Or sorry, that by CBG machine, perfusion machine.
For the purpose of HIPEC, sir?
Yeah. Instead of that HIPEC machine.
Okay, I think it's equally good. Only thing is, these HIPEC machines are available, so they are more circulation can be maintained. They're specific to it, but I think even for cardiac OTs, these perfusion machines may be appropriate. I've not used it, but appears to be okay.
Because we do it occasionally. No, we cannot afford to buy this thing. Like in a bigger center where you use 200, 300 cases per year.
Not per year. It's over last 4 or 5 years.
So I have gone through your review article in IJ.
Yes, sir.
2019. It is very good.
Yes, thank you.
Thank you, Rakesh.
I think those candidates who are preparing for DNB exam or some national exams like this, there could be a few questions